ഉണ്ണിമായിട്ട് പറ്റിയിട്ടുണ്ട് കുറച്ചുകൂടെ ബാക്കിയിട്ടുണ്ട്
എല്ലാക്കിയോ ഉണ്ണിമായിട്ട് സെറ്റ് ആയോ അതെങ്കിലും ആവട്ടെ
ബാക്ക്ഗ്രൗണ്ട് ആവത്തില്ല എന്റേത് അതാണ് പ്രശ്നം.
പിന്നെ ഓക്കെ അടിക്കാനൊന്നും ഇല്ലല്ലോ.
അല്ല അത് ലീവിയല്ലേ
ഇവിടെ വിത്തൗട്ട് വീഡിയോ ജോയിൻ ചെയ്യുന്നത് പക്ഷെ ഡൗൺ ആക്കിയ പോലെ
ജോയിൻ വിത്ത് കമ്പ്യൂട്ടർ ഉണ്ട്. ഇത് പേര്
ഞാൻ മെന്റലി
കണക്ട് ചെയ്യുന്നില്ലല്ലോ നമ്മൾ പറയുമ്പോൾ ഭയങ്കര സൗണ്ട് കുറച്ച് വേണം വേറെ
TDC കോട്ടയം കോട്ടയം ആരാണ് നോക്കൂ ആത്മജ അസിസ്റ്റന്റ് പ്രൊഫസർ ആത്മജ കെനയർ അസിസ്റ്റന്റ് പ്രൊഫസർ ഗവൺമെന്റ് മെഡിക്കൽ കോളേജ് കോട്ടയം.
മറിയ എന്റെ ഫോൺ എടുക്കുന്നത് ഞാൻ തരുമോ മാം ഒരു പേപ്പർ
ഇതിലുണ്ട് ഞാൻ അന്വേഷണം
വീഡിയോട്ടാ
കാരണം കുറച്ചൊക്കെ വേറെ ആൾക്കാരുണ്ട്.
പോയി മാറ്റി
Can you please? That's okay. Am I speaking to LWA? I'm going to can you please be ready with the session? Session will be soon.
Hello? Hello? Am I audible?
Yes, sir.
Yeah, but the voice is not clearly coming. It's not started yet, ma'am.
Good morning. Good morning, everybody. Welcome to the scientific session of Triple Conclave 2023. I welcome all the judges and delegates to this session. Today's scientific session will be paper presentation by postgraduates. I would like to welcome our judges to the session, Dr. Anshu Matthew and Dr. Ivy Elsa John, Assistant Professors of Pushpagiri Dental College, Tiruvalla. So we are beginning the session. Judges, kindly note, first presentation is postgraduate paper presentation number 24. PG paper 24.
Ma'am, can I start?
Yeah, you can start.
Am I audible?
Yes, you are.
I'll start now. A very warm good morning to one and all. I would like to start my presentation with a positive quote, that is, health is not just being disease-free. Health is when every cell in our body is bouncing with joy. My presentation for today is titled A Game Changer for the Crab. With this, let's look into the topic for today, that is nothing but theranostics in oral cancer. So what is theranostics? Theranostics is the emerging field in the branch of nanomedicine. The term theranostics was first introduced by John Funkhauser in the year 2002. Theranostics is nothing but it is a combination of therapy and diagnosis. The therapeutic applications of theranostics are chemotherapy, phototherapy, gene therapy, PET scan, fluorescence, MRI, and photoacoustic imaging. The radionucleotide, it is used at different dosages for therapy and diagnostic purpose. What we are seeing in this image is a radioisotope. It has a binding molecule that binds to the target and a linking molecule that binds to the radioisotope. Examples of this radiopharmaceutical like this are DOCA and PSMA 617. Coming to area of interest, that is oral cancer. Oral cancer is the sixth most common cancer in the world, and men are affected more commonly than women. The most common etiologic factors can be tobacco consumption and alcohol. Many studies found out that in head and neck cancer patients, there is abundance change in the oral microbiota, and this can be used as biomarkers for cancer detection. Coming to theranostics in oral cancer. MicroRNAs, these are non-coded RNAs that plays an important role in gene expression. Among the various players in cancer detection, the microRNA, it helps in maintaining the cancer cell stemness, and this property can be used in diagnosis and treatment. Peptides, these are short chain amino acids. These are developed to overcome the disadvantages and systemic toxicity of conventional anti-cancer treatment. Then interaction of mitochondria and cancer microenvironment is through the immune cells, cancer-associated fibroblast and nanoparticles. And this property can also be used in theranostic purpose. Then in an article by Lee Siu et al., they have found out the importance of microparticles. What they have done is they have collected blood sample from patients who are in stage 3 and 4 oral squamous cell carcinoma and centrifuged it. And the separated microparticles are coated with quantum dots, and it is infused into the living mice, and this living mice is examined. And this leads to the development of dual model technique of microparticles. And next is nanocurcumin. Curcumin is the active ingredient of turmeric, and nanocurcumin is developed to overcome the disadvantages like poor absorption of conventional curcumin. And this is nothing but it is a modified form of curcumin to improve its solubility and absorption. Photosensitizers, these are experimental cancer therapy. It is used in the detection of precancer. It is used for the detection and treatment of precancerous lesions and conditions. So to conclude, nanotheranostics, it is the emerging field in the medicine and dentistry, and it will definitely become an potential branch in the near future. Every once in a while, a new technology, an old problem, and a big idea turn into an innovation. These are my references, and thank you. Ma'am.
PG paper 24, are you still online? Can
Yes,
you hear?
yes, ma'am.
Did you hear the question?
No, ma'am.
Okay.
Effect of microRNA in the etiology of bone cancer.
Ma'am. Hello, ma'am.
Hello, am I audible?
Ah, yes, ma'am.
So what is the etiological factor of how microRNA affect bone cancer? How it is affected in the pathogenesis of bone cancer?
Ma'am, microRNAs, it is a key player in the stem cell cancer, tumor stem cell initiation, metastasis, and apoptosis.
So is it regulating the tumor suppressor gene or is down regulating the hormone genes of the cancer?
Ma'am, I don't know.
Thank you. Thank you.
Okay.
Thank you, ma'am. Now we have PG paper 25. Judges, please note PG paper 25.
Hello.
You are audible.
Is my screen being shared?
No, your screen is not visible. Now your screen is visible. Hello, are you still online? Are you still online? PG paper 25, you can start now. PG paper 25, do you have any technical issues? Can
Yes,
you
ma'am.
hear us?
Am I audible?
Yeah, you are audible.
Okay, ma'am. Can I start with the
Yeah,
presentation?
your time starts now.
Ma'am, just a second, ma'am. My screen is not visible. Hello, ma'am.
Yes, your screen is visible.
Okay, thank you, ma'am.
Yeah, you can start now.
Okay, esteemed faculty members and colleagues, a very good morning to all. Today I'm here to deliver my presentation on a study, effectiveness of photobiomodulation associated with myofunctional therapy in the management of temporomandibular dysfunction. A brief about temporomandibular joint dysfunction. It's a collective term used for an array of disorders, including the masticatory muscles, the temporomandibular joint, and the associated structures, like the discal tissue, the capsule, and the ligaments. The various treatment modalities used are physical therapy, pharmacotherapy in the form of NSAIDs, muscle relaxants, tricyclic antidepressants, occlusal splints, electrotherapy in the form of TENS and ultrasound, intraarticular injections like steroids, hyaluronic acid, laser therapy or photobiomodulation, and surgery, last resort. Out of all these, I'm choosing low-level laser therapy or photobiomodulation or cold laser therapy, as this is a very useful modality in the treatment of acute and chronic pain within the superficial joints and muscles, using a low power and energy output and a wavelength within the visible and infrared spectrum. Now, the various mechanisms by which it works is analgesic effect by the release of endorphins and hyperpolarization of nerves, tissue healing by release of vascular endothelial growth factor and collagen, anti-inflammatory effect by the release of nitric oxide, vasodilatation and angiogenesis, and also washout of inflammatory mediators. And the most important one, the biostimulating effect, in which the mitochondria is stimulated to release the ATP, and there is also decreased oxidative stress within the cells. Now, the aim of my study is to investigate the influence of photobiomodulation associated with myofunctional therapy in patients having temporomandibular joint disorders. And the objectives will be to evaluate the pain intensity, active range of mandibular movements, tenderness in masticatory muscles, quality of life improvement before and after therapy. The materials and methods will be, it is a randomized prospective pilot study with a total sample size of 20 patients, 20 women suffering from temporomandibular joint dysfunction, and the material used will be a photobiomodulation probe. Inclusion criteria. It consists of patients with TMD under the clinical examination diagnostic criteria, RDC TMD. And the age group will be 18 to 55-year-old females. The exclusion criteria, pregnant women, patients undergoing chemo or radiotherapy, and class 2 and 3 malocclusion. Methodology. 2 groups were taken, experimental and control group. Experimental group consists of 10 patients who underwent low-level laser therapy for 15 minutes, along with the myofunctional therapy for 30 minutes. And control group consists of 10 patients who underwent orofacial therapy with an inactive low-level laser therapy. The methodology, it consists of total 12 sessions in weekly meetings, that is twice a week for 4 weeks, with the first and last session for evaluation and the 10 sessions for clinical intervention. The laser parameters used were 980 nanometer of wavelength, 48 joule per centimeter square fluency, 0.8 watt power, 1 centimeter size spot size, 60 seconds of application time with the continuous mode and light contact mode. The laser probe was placed perpendicular to the target tissue and kept at every tender point for 60 seconds. It was followed by thermotherapy and physiotherapy at home for 30 minutes. The sites of laser application were condylar region, masseteric region, lateral pterygoid, and medial pterygoid. Now, the criteria evaluated were VAS intensity, number of tender points, joint sounds, maximum mouth opening with and without pain, laterotrusive movements, protrusive movements, and deviation on mouth opening. Oral health impact profile 14 questionnaire was also asked, which consists of total of 7 domains. The pre and the post therapy records were compared. The master sheet containing all the details of my patients. Now the results. In the first experimental group, it was found that there was statistically significant difference found in the p-value in the pre and the post therapy groups in pain intensity, number of tender points, and maximum mouth opening with and without pain. However, in the laterotrusive movements, protrusive movements, joint sounds, and deviation, not much of difference was found. These are the pictures, the pre-treatment and the post-treatment. In the control group, only statistically significant difference was found in the pain intensity. However, not much of statistical difference was found in rest of the parameters. When the experimental and control group were compared
Kindly note, you have 1 more minute.
Okay, when they were compared, it was found that high amount of difference was found in the vast tenderness and mouth opening in the experimental group, and not much difference was found in the control group. In the oral health impact profile, it was found that all the 7 parameters showed statistically significant difference in the pre and post therapy, whereas in the control group, not much difference was found except for 1 parameter, that is functional physical pain. When both were compared, it was seen that in the pre and post therapy groups, there was a difference of 17 in the experimental group, whereas it was only 6 in the control group. Also, out of all the patients of experimental group, only 2 patients reported back with recurrence of symptoms within the follow-up period of 4 months, whereas from the control group, most of the patients came back with recurrence of symptoms once the myofunctional therapy was stopped. Which brings us to the inference that low-level laser therapy provides a significant improvement in mouth opening, pain intensity, number of tender points, and oral health impact profile, whereas overall no statistically significant difference was found in most variables in the control group. Also, there is no statistically significant difference in the pre and the post-treatment values in late protrusive moment, protrusion, clicking,
Your
and
time is
deviation.
over. Kindly
However,
note.
results were superior to control group. Taking all these things into consideration, we reached the conclusion that low-level laser therapy has been shown to be effective and non-invasive modality in reducing the signs and symptoms of TMD. The findings are restricted to a specific set of parameters, so further research needs to be done at variable parameters and larger samples with longer time for follow-up. Thank you for your patience.
So what about the recurrence rate in your study?
Yes, ma'am, as I discussed already, out in the 4-month period, I found out of total of 10 patients who had already completed the therapy, 2 patients came back with the same symptoms once the therapy was stopped. So I found good results as such till now, but this study is still continuing in the department. So I have to see for this.
Consent was taken from the patients and ethical clearance?
Yes, ma'am. Yes, ma'am. Ethical clearance as well as consent was taken for the patient. Because of this, there were many dropouts also because they could not come to the department for total of 12 sessions.
Okay,
Yes.
thank you.
Welcome, ma'am.
Thank you. Now we have PG paper 27. Judges, please note PG paper 27.
Hello, am I audible?
Yeah, you are audible.
Just a minute, ma'am. I'll share my screen.
27.
Ma'am, is my screen shared?
Yeah, your screen is visible. Your time starts now. You can start now.
Yes. Respected judges and dear delegates, a very good morning. I'm here to present my thesis dissertation, which is titled Quantitative and Qualitative Assessment of Lingual Pet Thickness in Mandibular Third Molar Region using CBCT. Moving on to introduction. One of the severe complications of extraction of the mandibular third molar is lingual cortical plate fracture and displacement of the root fragment. Root fragment displacement associated lingual nerve damage along with lingual plate fracture is a severe complication on account of a thin lingual cortical plate. Hence, in this study, we evaluated the lingual plate thickness at 3 different levels, that is cervical, midroot, and apex, as well as the density at the level of midroot in mandibular third molar region using CBCT, and also determined the association of various risk factors with the lingual plate. Moving on to aims and objectives, the aim was to assess the lingual plate in mandibular third molar region using CBCT. The objectives were to measure the lingual plate thickness in the mandibular third molar region in the 3 different levels, that is cervical, midroot, and apex, to assess the lingual bone density in the midroot level of the mandibular third molar, to assess the correlation of lingual plate thickness and position of mandibular third molar, and also to assess the correlation between the lingual plate thickness with age and gender. The material and methods, it was a retrospective observational radiographic study conducted over a period of 3 years and using an ICAT FLX cone beam 3D system, and the images were analyzed in appropriate axial, sagittal, and coronal planes. The inclusion criteria had CBCT, images of good quality with complete visibility of the mandibular third molar in any configuration with the adjoining alveolar bone. The exclusion criteria had CBCT images of poor quality, mandibular third molars with incomplete. Hello, is my screen visible? Hello. Can I continue? Hello. Am I audible? Okay, hello. So the exclusion criteria is mandibular third molars with associated or involving large-scale carious teeth, cystic lesions or tumorous growths, and partially edentulous arches with mandibular second or first molar teeth, or anatomic changes secondary to any surgical treatment or procedures in relation to the third molars. The methodology was lingual plate thickness was assessed at three different root levels, where the appropriate coronal slice was selected and cervical third, midroot, and apex was identified, and measurements were made from different root levels to outer lingual cortical plate. The lingual plate density at the midroot level was analyzed using in vivo software tools. All other risk factors such as age, gender, location, number of roots, depth of impaction, and the mesiodistal and the buccolingual angulation were analyzed and documented in a specially designed proforma for the study. Age was categorized into 4 groups, and this was the proforma that was used for data collection. Ethics committee approval was obtained in January 2021, and 648 mandibular third molars of a total of 333 males and 315 females as per the inclusion and exclusion criteria were evaluated for the study, and data was collected. Moving on to statistical analysis, all the data were analyzed using SPSS software version 18. A p-value of less than equal to 0.05 was considered to be statistically significant. The comparison of the categorical variables was done using the chi-square test of Fisher's exact test, and the mean bone density at the midroot level was compared between thin and thick lingual plates using the Mann-Whitney U-test. The univariate and multivariate analysis was done using binomial logistic regression, and Cohen-Kappa test was used to detect.
Kindly note, you have 1 more minute.
Inner and inter agreements wherein Kappa showed perfect agreements with the Wilcoxon sign round test, showing no significant difference between the lingual plate thickness at the cervical, midroot, and apex, along with the lingual plate density at the midroot level. Moving on to results, table 1 shows age and gender distribution, table 2 shows distribution of the tooth and the number of roots, table 3 shows the distribution of impaction depth and angulation of the mandibular third molars, and table 4 shows the mean of lingual plate thickness and lingual plate density at the midroot level. Table 5 shows comparison of age groups with gender thickness of lingual plate, wherein a significant high proportion of subjects with thin lingual plate at the midroot was prominent in the 21 to 30 years age group, and a significantly high proportion of subjects with thin lingual plates at the apex were prominent in the 21 to 30 years of age group. Table 6 shows the comparison of lingual plate thickness with position and sum total of roots, wherein a significantly high proportion of subjects with thick lingual plates at the midroot level had an association with the number of roots. Table 7 shows the comparison of lingual
Your time
plate
is over.
with impaction depth, mesioangular, and buccolingual angulation, wherein a significant higher proportion of subjects with thin lingual plates at the midroot were associated with mesiodistal angulation. Table 8 shows the mean lingual plate bone density, wherein a significant association was noted with thickness of lingual plate at the midroot level. Table 9 shows the
Kindly wind up the session. Your time is over.
Ma'am, just 1 minute, ma'am, please. Univariate and multivariate regression shows the analysis of thickness of lingual plate at midroot level with significant p-values, and table 10 shows the univariate and multivariate regression of the lingual plate thickness at the apex, which also had significant p-values. Moving on to discussion between the age groups and thickness of lingual plates. Thinner lingual plates at the apex were seen in the age group of 21 to 30 years, which was in agreement with study done by Aksoy et al. And also Wong et al. The significant association was noted between the number of roots and thick lingual plate at the midroot level, which was in agreement to the data research done by Tolstonov and Mensideglu et al. Huang et al. And also Tolstonov et al. Stated that the bone around the horizontal and mesioangular impacted third molars were 3.6 times more likely to be thin than the width at the same bone around the vertical and distangular impacted tooth at the level of midroot level. Moving on to conclusion, our findings suggest that the lingual plate thickness had a strong association with age, angulation, and number of roots in the mandibular third molar. Thinner lingual plate has a strong association at the mid-root level with age group of 21 to 30 years, mesoangulation, and multi-rooted mandibular third molar. However, at the apex, thinner lingual plate was associated with the age group of 21 to 30 years and centrally positioned third molar. These are my references. Thank you.
Can I know how was the density of lingual plate measured?
Density was measured using the in vivo software, where Hounsfield units was a tool there in the software itself, where the density was measured using that tool.
Okay, what is the name of the tool?
Hounsfield units, ma'am. HU. There'll be a small button on the top panel.
Okay, how much is it reliable?
Ma'am, there's a debate regarding that, but it's not like 100%. But then they say it's a good enough value. Like for implant analysis, we usually give the bone density, so that works. Yes.
Okay, thank you.
Thank you, ma'am.
Thank you, judges. Now we have PG paper presentation, paper 28. Judges, please note, paper 28.
Yes, ma'am. Ma'am, can I start?
Yeah, you can start now. Your time starts now.
Okay, ma'am. Respected judges, a very good morning to all of you. Today, I'm going to present my research paper on comparison of efficacy of topical steroid and low-level laser therapy in the treatment of lichen planus, a comparative study. First off, introduction, as we know, lichen planus is a chronic inflammatory immune-mediated disorder that affects the skin, nails, and the mucous membrane. It was derived from the word lichen and the planus, first explained by the Erasmus Wilson, characterized mainly by the vacuum stray and is usually present bilaterally in mouth. Regarding the etiology, it can be multifactorial. It can be due to the psychological stress, systemic or viral infections, or due to the autoimmune disease. Anderson has clinically given the classification depending upon the clinical presentation as reticular, papular, plaque type, or blast type, or the erythematous type. Now, various treatment modalities have been used for the treatment and the management of the lichen planus, belonging to the pharmacological and the non-pharmacological side. One of the treatment modality that has been recently evolved is the low-level laser therapy. Because of the advantage, it has a good patient compliance, non-invasive, and no adverse effect on the patient. So, aims and objectives of my study were to compare the efficacy of the topical steroid therapy, which is the standard therapy, with that of the low-level laser therapy in the management of oral lichen planus. The objectives were to evaluate the response on the basis of two changes. One is the clinical symptoms, that is the change in the burning sensation, and other was the size of the lesion. So inclusion and the exclusion criteria. Inclusion criteria: patients with symptomatic oral lichen planus. Subjects were taken from 20 to 70 years, and those which were using to take the medicine. Exclusion criteria was those who were allergic to the drugs, or having any history of malignancy, current generalized infections, or organ transplantation, or history of pregnancy and breastfeeding in case of females. Coming to the study design, our study was a pilot study. It was conducted on the 20 patients that visited to the department that were diagnosed as oral lichen planus as per the modified WHO criteria. We randomly categorized the patients into two groups, Group A and Group B. In Group A, they were given the low-level laser therapy, and Group B was given the pharmacotherapy. And informed written consent was taken from the subject after explaining the purpose, nature, and the objective of their study in their own language. So materials and method: in Group A, we used a 980 nanometer diode laser giving a wavelength of 980 nanometer with a power output of 0.5 for a maximum period of 3 minutes, giving a total energy of 90 joules. It was used in a non-contact, non-focused, continuous mode with scanning movements, and the patients were given 2 sessions per week for a maximum of 3 weeks. In the pharmacotherapy group, the patients were asked to apply topical steroid, trimestone acetonide, which was applied for 4 times a day, which was for a maximum period of the 3 weeks. Evaluation of the patients was done on 2 criteria. First was the burning sensation, which was calculated on the as per the VAS score, which was an 11-point scale from 0 to 10. And another was the change in the size of the lesion, which was given scoring as per the Thompson scoring system, which is as follows, in which the score was given from 0 to 5. Coming to the results, our results showed that, first of all, age distribution. Our results show that the mean age distribution in case of both the groups was about 48 years. And in case of the gender distribution, out of 10 patients which were allocated to each group, 7 were females and 3 were that of the males. Now coming to the results regarding the VAS score, we can see that there was a significant decrease in both the groups, but in case of the laser group, there was a decrease in the VAS score from 8.3 to 1.2, and in case of the steroid group, it was decreased from the 6.7 to 1.9, showed that there was more decrease in the VAS score in group B as compared to the group A. Now coming to the percentage reduction, in case of the VAS score, it was more in case of the laser group therapy, in which there was percentage decrease up to 85%, whereas in case of the steroid group, it was about 75%, slightly lesser than that of the laser group. When considering the size of the lesion or the healing, the percentage reduction was seen that in case of the laser group, there was a percentage reduction up to 53%, and while in case of the steroid group, there was a percentage reduction up to the 58%. So showing that the steroids was better in case of the healing of the lesion was considered, but laser was better when we considered the pain of the lesion. So these were some of the cases that we are conducted. This was the follow-up of the patient after the 3 weeks, showing the reduction in the size of the lesion as well as reduction in the symptoms. This was another case with the reticular type of lichen planus. These were the cases which were treated by the steroid group, showing the reduction in the size as well as the symptoms. Now coming to the conclusion, a general improvement was seen in both the groups. A significant
Kindly
improvement
note, you have 1 more minute.
A significant improvement was seen in the VAS score when we compared the low-level laser therapy with that of the steroid, and a significant reduction was seen in the size of the lesion, which was more in case of the steroid group as compared to the low-level laser group. So we can conclude with this that low-level laser therapy can be used as an adjuvant to the steroid, or it can be used as a treatment modality in cases where steroids cannot be used. But some of the limitations of our study were that specific parameters were only taken. Sample size was very small because it was a pilot study, and the follow-up of our study was very short. It was only up to 3 weeks. Thank you.
Can you hear me?
Yes, ma'am.
Okay, how did you confirm patients with lichen planus? Did you do any histopathology?
Yes, ma'am. Yes, ma'am. Those patients were underwent histopathology only. Then we took those patients by histopathology. Okay. We first confirmed them.
Did you categorize to any types of lichen planus, or like did you take any special type of lichen planus, either reticular or erosive or something like that, or generalized the group?
Most of the patients were erosive type, but we took all those patients which were symptomatic, which came with the complaint of burning sensation. Out of these 3-4 patients were also of reticular type also.
But then histopathology was done. Only after the confirmation you selected the patients.
Only, ma'am, in case of the erosive cases. We didn't did histopathology for reticular cases.
Okay, so you have some with histopathology and some without.
Yes, ma'am. Yes, ma'am.
Okay, thank you. So it's always better you do histopathology and confirm and then take patients. So there won't be any bias when you select the patients.
Yes, ma'am.
Thank you, judges. Thank you, doctor. Now we have PG paper 29. Judges, kindly note PG paper 29.
Yeah, good morning, ma'am.
Yeah, good morning.
Yeah, can I share my screen now?
Yeah, you can share your screen.
Yeah. Here.
Okay, you can start now.
Yeah, okay. So my topic is alterations in serum lipid profile patterns in oral cancer patients. The aim and objectives. The aim is to evaluate the several serum lipid profile parameters among oral cancer patients. The objective was to find out whether there is any correlation between the serum lipid profile of oral cancer patients as compared with the non-cancerous study population. In this sample size, I have selected 75 participants. 50 is from oral cancer group, and other 25 is from the control group population. Inclusion and the exclusion criteria. The inclusion criteria was subjects were divided into 2 groups. Control group were healthy persons and probably other illness without any oral cancer, and the factors influencing the normal lipid profile. The other one is a study group with the SCC, persons suffering from different grades of squamous cell carcinoma of the oral cavity. The participants were chosen in the age group of 19 to 78 years of the age. The participants' body mass index was less than 28. The participants were on the average Indian diet. The exclusion criteria were The people having below mentioned diseases excluded: diabetes mellitus, nephrotic syndrome, alcoholism, hypertension. People who are on following drugs are also excluded: HMC-CoA reductase inhibitors, fabric acid derivatives, beta blockers, nicotinic acid, and diuretics. People who are on abnormal diet. After the study of the serum plasma and the test of the lipid profile, the parameters we assess is total cholesterol. In the control group is 193.76 plus minus 8.64. In oral cancer patient, it was 178.56 plus minus 14.66. The p-value was less than 0.001%. In total triglyceride patient, 112 plus minus 11.75. And oral cancer patients, 100.78 plus minus 12.39. Here is also the p-value is less than 0.001%. HDLC, which is a good cholesterol, in the control patients, it was 48.40 plus minus 6.53. But in the oral cancer patient, it was 40.78 plus minus 7.13. It is also plus less than 0.001%. And the same along with the LDL and the VLDL also. There is significant reduction in the p-value. Serum lipid profile, also according to histopathological, we have also taken the histopathologically grade. The total cholesterol was 175.64 plus minus 14.78, 179.93 plus minus 14.91 in the moderately differentiated patients, and the poorly differentiated there was 179 plus minus 14.75. The significant reduction in all the parameters of the lipid profile also was there in the histopathological grade. Serum profile comparison between no habit of tobacco. We also considered the patients of the no habit of tobacco and the with the habit of tobacco subject in the oral cancer and the control groups. Here is no any relevant feature was seen whether patient is on tobacco or it was not on the tobacco. The statistical data is also there. Among the male studies, 62.33% non-oral cancer patients were there. Oral cancer patients 68%, in females 37.67% and 32%. Same manner we have the graphical presentation what I have told earlier. In this manner we have find a significant reduction in the lipid profile ratio, especially total cholesterol, total triglycerides, and VLDL and HDL. These are the graphical presentations I have followed in the histological. Histological parameters are of same them. Summary of the results I have found.
You have 1 more minute.
A good systemic and well-pronounced declining trend in all selected study plasma lipid profiles is clearly visible from the relative deviations of the average values of each lipid parameters of oral cancer patient group. An overall remarkable declining level in percentage deviation of the each lipid profile for non-cancer patients to oral cancer patient cases. Furthermore, reduction in all such Susan lipid profile parameters except in the case of HDL in oral cancer patient study. Conclusion: the main objective of the study is an assessment of alteration in serum lipid profile parameters in oral cancer patients as well as for non-oral cancer patients. We found the lower plasma lipid status may be a useful biomarker indicator for initial changes occurring in the neoplastic cells, plasma, TC, HDL, LDL, and TGL values. The observed lower p-values lower than 0.04 also give furthermore confirmation and statistical support about the validity of the clear reduction. The main outcome of study is that lower plasma lipid status may be a useful biomarker indicator for initial alterations occurring in neoplastic cells. Thank you, sir, ma'am, and audience for their patience.
Good presentation. So how will you stage the patients of oral cancer? Is like any criteria for staging oral cancer, the lipid profile?
Ma'am, it was the randomly. I have been practicing since 15 years. I'm randomly checked the CBC and all tests along with the lipid profile. Then I have found from that time also that severely there is a significant reduction in the lipid profile ratio in those patients. And then I have found a selection of the patients also. On the basis of that study, I have found it, and then I have chosen the cancer patients, and then the statistical data was found.
Cancer patients, is there any staging? Cancer was staged?
Cancer, earlier it was not, ma'am, it was randomly selected. But after that, when I have found these significant decline in the lipid profile ratio, then I have selected the oral cancer patient especially.
Okay, thank you.
Thank you, ma'am. Thank you.
Thank you, judges, and thank you, delegate. Now we have PG paper 30. Judges kindly note PG paper 30.
Am I audible, ma'am?
Yeah, you are audible, and your screen is also visible.
Good morning, ma'am. Good morning. Today I am going to present on comparative efficacy of low-level laser therapy, pharmacotherapy, and TENS in the symptomatic relief of temporomandibular joint disorder. Temporomandibular disorder is a set of clinical conditions that include disorder of the temporomandibular joint and masticatory muscles. Clinical features include pain in the joint and muscle tenderness, joint knives and clicking, limited or asymmetrical jaw movement. Etiology is multifactorial, including occlusal disturbance, trauma, parafunctional habit, stress, and disjoint relation. A number of treatment modalities are used for the management of temporomandibular disorder, which include conservative approaches, pharmacotherapy, and physical therapy. Low-level laser therapy has evolved as an efficient, non-invasive therapeutic in with the aim to evaluate and analyze the efficacy of low-level laser therapy, pharmacotherapy, and TENS in patients suffering from symptoms associated with TMJ disorders. The objective of the study was to assess the clinical symptom in patients with TMJ disorders, to evaluate incidence of patients suffering from TMJ with respect to age and gender, to compare response of 3 different treatment modalities in management of symptom of TMJ disorder, that is LLT, pharmacotherapy, and TENS therapy. Materials and method. This is a prospective pilot study conducted on patients reporting to the Department of Oral Medicine and Radiology. 30 clinically diagnosed symptomatic patients were included in the study based on diagnostic criteria for TMJ and the following inclusion and exclusion criteria. The study group, total 3 groups were taken. In each group, 10 patients were taken. Group 1 patient received LLT therapy. Group 2 patients received combination of gabapentin and nortriptyline, and group 3 patients received TENS therapy. Methodology. In group 1 patient, low-level laser therapy was given by using 980 nanometer diode laser in a non-contact, non-focused continuous mode at the preauricular area and tender point within the muscle. Total 2 sessions per week for a maximum of 3 weeks were given. Group 2 patients received combination of 100 mg gabapentin and 10 mg nortriptyline once daily for 3 weeks. And group 3 patient received TENS therapy at a frequency of 50 Hz and intensity adjusted according to the patient's tolerability. 2 sessions per week for 15 minutes per sitting for total 3 weeks. Evaluation of patient. All the patients were examined and assessed at baseline and at each week for 3 weeks. The patient were evaluated for intensity of pain, which is recorded by visual analog score, comfortable mouth opening, that is maximal pain-free mouth opening, and third is muscle tenderness score. The muscle tenderness score was calculated by palpating the masticatory muscle and then grading each muscle, that is mild, moderate, and severe. And then muscle tenderness score was calculated by sum of individual score of each muscle. This is a result. The demographics of the study, out of the total 30 patients, the 30% were male patient and 60% were female patient. The mean age of the patients was 27.8 years. Of the 30 patient, 30% patient have pain in the right TMJ region, 63.34% patient have pain in the left TMJ region, and 6.6% patient have bilateral pain. The table 1 show comparison based on bar score between the 3 groups. As we see in the table, in the LLT group at the day 0, the mean value of bar score was 6.4, which reduces during the treatment to 1.5 at the end of treatment. Whereas in the pharmacotherapy group, it is 6 at the baseline and decreases to 1.9. Whereas in the TENS therapy group, the mean value was 6.3 and decreases to 2.7. So LLT therapy show more effective reduction in VAS score, that is 4.9, followed by pharmacotherapy and followed by TENS therapy. The table 3 show comparison based on comfortable mouth opening between the 3 groups. In the LLT group, the mean value of maximum mouth opening at day 0 was 31 mm, which increases during the treatment.
Kindly note, you have 1 more minute.
Which increases during the treatment, that is 3rd week, 40.7 mm. In pharmacotherapy group, it is 33.5 mm and increases to 40.2 mm, and in TENS therapy it is 31.6 and increases to 37.4 mm. So LLT group have more increase in mouth opening, followed by pharmacotherapy, followed by TENS therapy. This is a table 5 show comparison based on muscle tenderness in the 3 groups. In this table, we see that muscle tenderness score was more reduction in muscle tenderness score in LLT group, followed by pharmacotherapy. So I am concluding my study that there is a general improvement was seen in all the 3 groups and were effective in decreasing the symptom of TMD patient. However, therapy was found to be more effective than pharmacotherapy than the TENS therapy. So LLT can be considered as an independent treatment modality in managing the symptom of patients suffering from TMJ disorders because it has minimum adverse effects.
Kindly note, your time is over.
Have no allergic side effect. Thank you, ma'am.
इसको एक बार जरा देखो, कुछ जब से इसको इसने ठीक किया ना, ये चेंज किया ना,
It was a good presentation. So what are the pharmacotherapy used for your patients? Am I audible?
PC paper number 30. Can you hear?
Hello.
Can you hear now?
Yes, ma'am.
Did you hear the question?
So what was the pharmacotherapy used in your study in the patients?
Ma'am, I used a combination of gabapentin 100 mg and nortriptyline 10 mg once daily.
So the LLT was significantly improved than the pharmacotherapy and the other?
Yes, ma'am.
Thank you.
Thank you, ma'am.
Thank you, delegate, and thank you, judges. Now we have PG paper 31. Judges, kindly note PG paper 31. PG paper 31, are you there?
Yes, ma'am. Yes, ma'am.
Yeah, please share your screen. Yeah, you are audible. Please share your screen.
Yes, ma'am. Visible?
Yeah, your video, your screen is visible and your time starts now.
Okay. Good morning, all. The topic of my today's paper presentation is CBCT guided implant surgery, a review. The content of my
My presentation, introduction, surgical guide, protocol, advantage, future aspect, and references. In introduction, guided implant surgery industry involves the process of constructing intraoral state, three-dimensional, with the help of high quality CT, and using this planning implant for a as you can see in the diagram, they have given the radiographic image of CBCT. Second, important in surgical in guided surgery is surgical, and you can also see call it as a surgical. So it is a used to place a pin in an accurate position. So it is three types. It is of three types. Tooth supported, mucosa supported, and
So, PG paper 31 is facing some technical issues. So let's move to the next candidate. That is PG paper 32.
I have to complete my presentation. Ma'am, I am paper number 31.
Yeah, yes.
Can I share? I am 31.
Yeah, then you can continue.
Yes, ma'am. Sorry for the. Okay. So protocol guided implant surgery. The first thing is to make the radiographic implant. Second, the virtual planning in the CBCT scanning of the full mouth to scan for the tooth to be placed. So in the virtual implant plan in the posterior in the time you can see they have given the image of the posterior table. They have a section scan into in the three planes, like axial, cross sectional, and tangential. So in the you can see that they have the virtual treatment planning in the posterior illustrating in different planes and also in the panoramic.
आज पता चलेगी ना क्या
PG paper 31, are you facing some technical issues?
Software construction of the precise. Then here is a diagrammatic representation of the surgical guide. In the placement of the guide allows the precise and pre-planned surgical positioning of the implant. So next is here is a diagrammatic representation of the fully edentulous guide lies with the horizontal pins, patient's bone following guided drilling and implant.
Paper 31, you can do the presentation at last since you are facing some technical issues. So we can move to the next one, PG paper 32. Judges kindly note PG paper 32. PG paper 32. Your screen is visible. You can start now. Can you hear me?
अभी नहीं बैठ सकती लाइब्रेरी में भी उधर कहाँ मैं लाइब्रेरी में जाऊंगी
Hello. Am I audible, ma'am? Hello.
Yeah, you are audible. Hello.
Hello.
Hello, paper 32. You are audible, but your screen is not visible now. You haven't shared your screen. Are you there?
One minute, ma'am. Yes, ma'am, I'm here.
Yeah.
Hello.
Yeah, your audio is clear.
Ma'am, is the screen visible now?
Yeah, now the screen is visible.
Okay. Okay,
You can
ma'am.
start now.
Okay. A very good morning to all of you. I'm going to start my presentation titled Comparison of Effect of Different Treatment Modalities, that is low-level laser therapy, traditional conservative treatment, and a combination of both on biomarkers, that is HS, CRP, and interleukin-6, and pain intensity in patients with temporomandibular disorders. Now, introduction. Temporomandibular disorder is a collective term embracing a number of problems involving masticatory muscles, TMJ, and associated structures. The patients can present with facial pain, limited movement, deviation, hyperalgesia, and TMJ sounds. The various causes include biomechanical causes, biopsychological, neuromuscular, and biological causes. Now, what are biomarkers? Biomarker is defined as a characteristic that is objectively measured as an indicator of a normal biological process, a pathological process, or biological response to a therapeutic intervention. Synovial, serum, and urinary proteins, they demonstrate useful diagnostic value for temporomandibular disorders, but no perfect and direct package of disease markers for TMDs are available. The most likely biomarkers available are interleukin-6, interleukin-8, interleukin-1, and tumor necrosis factor. What are cytokines? They are released from the monocytes and macrophages, which infiltrate the synovium and then release these cytokines. They reduce the lubrication and nutrition of the articular cartilage and this disc. Proteinases, they deplete cartilage proteoglycans. They are stimulated by cytokines, and they are produced and released during inflammation. Now, HSCRP is a C-reactive protein which was first isolated in the blood serum in 1930 by Tillett and Francis. Concentration may be increased even 1,000-fold within 40 to 48 hours of the onset of inflammation. And HSCRP detects low level of protein. It measures in the range of 0.3 to 10 milligram per liter. Various treatment modalities for TMD disorders involve conservative modalities and irreversible modalities. Conservative includes psychological physiotherapy, pharmacotherapy, splint LLT, triple LT, self-management, and irreversible includes surgery, orthodontics, and occlusal adjustment. Now we are using low-level laser therapy. It has different effects. It has an analgesic effect by increased metabolism of acetylcholine cortisol, which reduce stimulation and perception of pain. Biostimulating by release of ATP, that's growth factors. They accelerate replication and repair mechanism, decline oxidative phase. And it has anti-inflammatory factors. They alter blood flow, lymphatic drainage, and induce angiogenesis. Now, the aim of our study is to compare the effect of different treatment modalities on TMD biomarkers and pain intensity before and after receiving treatment. Material methods. It's a prospective pilot study which was done in the Department of Oral Medicine and Radiology. 18 patients were selected with temporomandibular disorders on the basis of diagnostic criteria for temporomandibular disorders. Both atherogenic and myogenic patients were included, and these patients were assigned to 3 groups with 6 patients in each group. Then evaluation of serum IL-6 and HSCRP was done before the treatment was started, and then patients were treated with LLT, conservative or combination therapy, and then re-evaluation of interleukin-6 and HSCRP was immediately done after the treatment was finished. Methodology in group 1, that's the conservative treatment, hot towel application, mouth opening exercise, and diet and stress counseling was done. In group 2, low-level laser therapy is in this low-level laser therapy at different ender points of on different muscles of mastication was done. Duration was 60 seconds at each ender point. And in group 3, low-level laser therapy and conservative treatment was done. Then intervention, 5 sessions of low-level laser therapy were given. and on alternate days starting from 0 to 0, 2nd, 4, 6, and 8 days for a duration of 60 seconds at a distance of 1 centimeter. The laser equipment used was a diode laser with a wavelength of 980 nanometer, frequency of 48 joule, and duration was 60 seconds. This was group 1 and group 2. That's the standard conservative treatment. We have already discussed that we will give hot towel application, diet and stress counseling and therapy.
Kindly note, you have 1 more minute.
Then age distribution was like this: females, most of the patients while females, and age range was 27.5, 23.5, and 26.5. Then pre-treatment was shown in group A, VAS was 8.67 with a standard deviation of 1.03. Interleukin 6 was in group A. In group B, it was 8.17, 2.40, and 1.92. In group C, it was 8.33, 3.80, and 0.80. Post-treatment, the VAS was in group A, 5.83, 0.38, 1.21. Group B, 2.67, 1.92, and 1.74. Group C, 2.17, 0.80, and 0.91. The Pearson correlation analysis was done, and it was shown pre-treatment in IL-6 pre-treatment it was 0.081, and post-treatment was 0.092, and HSCRP was 0.367, and post-treatment 0.137. Conclusion: no significant correlation between pain intensity and biomarker level.
Thank you. Note, your time is over. Your time is over.
Okay, thank you, ma'am.
Good presentation. Can I know how are you going to sterilize the laser probe after every patient?
Ma'am, we used alcohol swabs. We used to sterilize, and the laser we have given, we give it at a distance of 1 centimeter. We have not touched the skin of the patient.
Okay, so you have not come in contact with patients.
No.
But still, you are doing any sort of sterilization just
Yes,
by.
We sterilize the tip of the laser with alcohol swabs, but we have not contacted any patient directly.
Okay. Okay, thank you.
Thank you, doctor, and thank you, judges. Now we can move to PG paper 33. PG paper 33. Judges kindly know PG paper 33.
Yes, ma'am. I'm there. Ma'am, can I share the screen?
Yeah, you can share your screen.
Ma'am, is it visible?
Not yet. Yeah, now your screen is visible. You can start your presentation. Paper 33, are you there?
Ma'am, am I audible?
Yeah, you are audible. You can start your presentation.
Okay. Good morning, respected judges and seniors. I will be presenting an unusual case of central giant cell granuloma, a case report. Introduction. Central giant cell granuloma of the jaw is a benign intraosseous osteolytic lesion with a debatable etiology. Its incidence is estimated to 0.001%, with the 60% of cases occurring below the age of 30 with slight female predilection, mostly seen in a case, a 54-year female patient swelling in the upper right front region was there since 6 months. It was painless, but the patient had discomfort ultimately in extraordinary examination, anteriorly from the midline, superiorly from the line joining the allotragus line of the ear till the corner of the mouth. It is non-tender, bright, soft, and the lymph nodes were non-palpable. In the area of examination, on the labial gingiva of 1 to 1.314 and wide by 4 centimeter in size. It was single shred, and on palpation, the swelling was non-tender in nature. The patient has no medical and past dental history. In an intraoral examination, the teeth there was generalized adhesion. The periodontal status was poor with calculus and with mild supragingivally, grade 3 mobility with 3-4. And there was periodontal pocket with 1.3, 1.4, 1.5, 1.6, and bleeding of probing was to the clinical diagnosis was made as central giant cell granuloma and chronic generalized periodontitis. With the differential diagnosis, oral pyogenic granuloma, and fibrous dysplasia was taken. With the radiographic finding on CBCT in the anterior maxillary region with 1.3, 1.4, 1.5, there was a mixed radiopaque radiolucent lesion which was seen, which was mesoid amorphous radio 1.4, 1.5, and thinning of cortical plate between 1.3 and 1.4, and there was root resorption which was seen in 1.4 and 1.3. On histopathological finding was seen as numerous multinucleated giant cells which was diffusely distributed within the background of plump ovoid and spindle-shaped mononuclear cells. The giant cells contained 6 to 20 nuclei, and there was bony stratified squamous cell epithelium showed ulcerations at some places. The final diagnosis on overall clinical and radiographic and histological features was as CGCG of the jaw is a rare benign tumor occurring below the age of 30 with slight female predilection. The case which was presented,
Kindly note you have 1 more minute.
Unique plate thinning or perforation, which is reported in a case and indicative of considering the lesion as an aggressive type. Thank you.
Good presentation. What was the radiographic differential diagnosis you given after CBCT?
Differential diagnosis was ossifying fibroma.
Okay. Okay, only one diagnosis was given.
No, ma'am,
radiographically.
as well as no, ma'am, fibrous dysplasia or giant cell tumor.
Okay, thank you.
Thank you, ma'am.
Thank you, judges, and thank you, delegate. Now we have PG paper 34. Judges, kindly note. PG paper 34.
Good morning, ma'am. Am I audible?
Yeah, you are audible.
1 second.
You can start now. Your screen is with me.
Good morning, everyone. Today I'll be presenting my paper, Follicular Stimulating Hormone, Luteinizing Hormone, and Prolactin Serum Level in Patient with Oral Lichen Planus in comparison to the healthy population. Introduction. As we know, oral lichen planus, it is a chronic autoimmune oral mucosal disease affecting 1 to 2% of the population worldwide and is characterized by its recurrence and chronic protraction course. Etiology is unknown, with the immunological system plays a substantial role. And we can see that there is a susceptibility of women for autoimmune diseases because the sex hormone, they alter the function of lymphocytes, affecting the production of immunoregulatory factors, expression of cell surface antigens, or ability to interact with other cells. There are other available evidence which indicate that T cells may be the major target of the sex hormone action. Now, how the CD8 cells mediate induction of keratinocyte apoptosis. It can be seen by three mechanisms: secretion of the T cells of the tumor necrosis factor, which bind TNF alpha receptor 1 on the keratinocyte surface 3, expression on the T cell surface of the CD95, which binds CD95 on the keratinocyte surface, infusion of the granzyme B by the T cells into the keratinocytes by perforin-induced membrane growth. The aim of the study was to evaluate the possible role of the follicle-stimulating hormone, prolactin, luteinizing hormone in the Kashmiri population with OLP compared with the healthy population. This was a cross-sectional study, case control study done on women with OLP who have been referred to the postgraduate department of oral medicine and radiology. And the sample size, 15 patients with OLP were considered for the inclusion criteria included clinically diagnosed lichen planus following the international diagnostic criteria, exclusion, pregnant female, lactating female, those who are on active hormonal therapy, or those with any autoimmune disorders, any inflammatory diseases, or any malignancies. These are some of the cases which were taken. The sample collection for the evaluation of these hormones were done in the menstruating women. It was done on the second day of the follicular stage, 2 hours post-awakening, while in case of postmenopausal women, the later condition was taken up. That is, the sample was taken 2 hours post-awakening in the morning. These are my results. This table shows the comparison of the hormone between menopause participant of the OLP and healthy control group. As you can see that the prolactin level, FSH and LH level, it varies. In the patient, it is 10 and 14 respectively mean, and FSH 88 and 64 respectively patient control, LH and 44 20. There was no statistically any significant differences between these. These are the comparison of the hormone between non-menopause participant of the OLP and healthy control group. As you can see, there are no significant differences in the level of this hormone. This table shows the mean serum level and comparison of all these three hormones between the menopause and non-menopause women. As you can see from the prolactin level, there is no statistically significant difference in the mean value between the non-menopause and menopause patient. But in FSH, you can see in the menopause patient, there are high raised level of FSH, which is statistically significant, as well as luteinizing hormone, which is also statistically significant. But we can also see that the distribution of FSH, LH, and prolactin also in the healthy group, FSH and LH level are difference in this menopause and non-menopausal patient. They're statistically significant. We can conclude that the mean serum level of the FSH and LH were significantly higher in the OLP patient, but as there is no significant difference reported for prolactin, and FSH serum level is seen very significantly higher in non-menopausal OLP patient, which is statistically significant. Thus, we can conclude that this FSH and LH fluctuation can affect the OLP pathogenesis, because the overall higher serum level of FSH and LH in OLP patient, which indicates that there is a which can be indicative of a lower level of estrogen and progesterone, which is related to this OLP pathogenesis. Thank you.
Presentation. What panels was taken in your study?
Sorry, ma'am.
How would you diagnose lichen planus, and what type of lichen planus was taken up in your study?
Ma'am, all the type of lichen planus was taken up in my study, and they were histopathologically diagnosed. But as such, characterization was not done. Whether it was, I'm also the study is still undergoing, and I'm comparing how the hormones affect the type of lichen planus. So I'm categorizing into non-erosive and erosive form of lichen planus. But this study is still undergoing in the department.
So it will give more significance if you have that correlation like in erosive and reticular type because of the malignant chance. So that will be of more significance. Okay,
yes, ma'am.
presentation.
Yes, ma'am.
Thank you, delegate, and thank you, judges.
Excuse me, ma'am. Excuse me. I am paper number 31. My presentation was incomplete. Can I do it now?
Yeah, you can do it now. Judges kindly note PG paper 31.
Hello everyone, sorry for the net issue. The topic of my paper presentation is CBCT guided implant surgery, a review. These are the content of my presentation. In introduction, the guided implant surgery in dentistry involves the process of reconstructing intraoral state in 3-dimensional with the help of the high quality CBCT and using this data for planning. So the main ingredient of the surgical guided surgery is surgical guide or template. It is a device which is used to place an implant in accurate position. It has 3 types: tooth supported, the guide which supported with the tooth. Second is mucosa supported, and third is bone supported. It has different types according to the dental status of the patient, and it has 3 different types of designs. That is non-limiting, second is completely limiting, and partially limiting. Then the protocols for guided implant surgery. First process is formation of the radiographic template. Second is CBCT scanning of the patient or the tooth to be replaced. Then third is the virtual planning of the treatment, where the virtual implant planning in the diagram we can see the planning in the posterior mandible, illustrating the different cross-sectional panoramic views and 3-dimensional images of the scan subject. So the virtual software allows virtual software planning allows for the construction of the precise surgical guide, and here we can see the placement of the guide allows for the precise and pre-planned surgical position of the implant. So this is the diagrammatic representation of the fully edentulous guide. It is stabilized with the help of the horizontal spin in the patient's bone. Following the guided reading, the implant are placed through the guide hole. The advantages of this guided surgery is it is more precise and accurate procedure for the placing implants. It preserves the vital anatomical structure by allowing the visualization of the relationship between the plan restoration and the bony anatomy. It reduces the time necessary for the implant surgery. Due to extensive planning prior to the implant placement, there is fewer unexpected findings during the surgery. The most important advantage in the involvement of all dental care providers from the beginning. It ensures the comprehensive diagnosis, treatment planning, and better outcomes. The active collaboration of the maxillofacial radiologist, surgeon, restorative dentist, and technician results in the predictable final outcome and avoidance of the problem that might otherwise require complicated and extensive surgical and prosthetic revision and remain unresolved, thus precluding the implant therapy for the patients. Associated with the implant surgery and their prevention, following are some suggestions or strategies. The complete understanding of the possible risk is necessary. Knowledge of the system and tools used is essential. A surgical procedure after each step is crucial. Proper training and surgical experience are critical. The future aspect of guided implant surgery are the combination of the intraoral scanner and CBCT images by manual superimposing and use of planning software provide an almost complete 3-dimensional representation of soft and hard tissue. In addition, novel planning software allows creation of the digital backup of the future prosthetic plan, which can be viewed and improved if needed. The milling and 3-dimensional printing technology have replaced the laboratory-based and sandblast large grid acid etch technology, which might improve the accuracy of the implant placement and related treatment. The dental implant navigation system requires the comprehensive pre-operative planning and the high-quality digital imaging for the improved performance. The application of the learning curve concept of to the medical industry is often exploring the effect of the surgical complications and operations time. However, there is no study yet investigated learning curves related to dental implant navigation system. Yes, the establishment of such learning curve can improve the system operation accuracy by increasing the operational experience, thereby providing patients with a safe and the high quality care. These are the references I used for this review. Thank you.
Hear me? Can you hear me?
Yes, ma'am.
Okay, so what are the databases that you selected while doing this review?
Sorry, ma'am, I get, can you repeat?
What all databases did you select? Like, which all databases did you search for while doing this review?
Ma'am, from the history of, ma'am, ma'am, you need an application. I
no,
have
I'm not
did
asking.
the research.
I'm not asking for application, something like PubMed indexed, or did you go for something PubMed or Scopus?
Yes, ma'am. Yes, ma'am. I
You
did
had
it
something
from
in
PubMed
particular?
and Google
Okay.
Scholar.
From Google Scholar. Okay.
Google
Thank
Scholar.
you.
Yes, ma'am.
Okay, thank you.
Thank you, ma'am.
Thank you, delegate, and thank you, dear judges. So we are winding up the session. Once again, thank you, dear delegates and judges. So the results will be announced later. Thank you all.
ഹലോ ചേച്ചി കേക്കാമോ?
Screen.
Please don't use the Wi-Fi on your
It's not.
वीडियो ऑफ है ना
Video. Good afternoon. Shall I confirm the PG paper presentation? PG paper 1. Hello. PG paper 1. Hello. Good afternoon. Shall I confirm PG paper 1?
Ma'am, I'm PG paper 21, ma'am. Hello.
Good afternoon. Shall I confirm PG paper 1?
Ma'am, I am 1, ma'am.
Audible ആണോ നീ വേഗം ബ്ലൂടൂത്ത് കാണിച്ചു സൗണ്ട് വരുന്നില്ല അതാ
So if you audible,
Good afternoon. Are we audible? Are we able to be heard?
ഒന്ന് കേറി നോക്കി. ഈ ഹെഡ്സെറ്റിന് കുഴപ്പമാണോ? അല്ല. Are you audible?
On mute.
Good afternoon.
Good afternoon, ma'am. Yes, you are audible. Hello.
Good afternoon. Are we audible?
Yes, sir.
Okay, good afternoon. Let's confirm PG paper 1. PG paper 2.
Ma'am, I'm PG paper 1.
Okay,
Hello?
Okay.
Yes,
Then PG paper 2. PG paper 2. PG paper 3.
Excuse me, ma'am. Our numbers start from 21 to 30, ma'am.
Okay, sorry. PG paper 21.
Yes, ma'am, I'm there.
PG paper 22.
Yes, ma'am. I'm here.
PG paper 23. Hello. PG paper 23. Okay. PG paper 24.
24 is here, ma'am.
Okay. PG paper 25.
25 present, ma'am.
PG paper 26.
26 present.
Okay. PG paper 27. PG paper 27. PG paper 28.
28, I'm here.
Okay. PG paper 29. PG paper 29. Okay. PG paper 30. PG paper 23. PG paper 27. PG paper 29. PG paper 30. Good afternoon. Pushpagiri College of Dental Science is delighted to host Kerala State 5th Annual Conclave. Let's start the scientific presentation under Department of Oral and Maxillofacial Pathology. Starting with postgraduate paper presentation, now going on to session 3, hall 3. We invite judges for our session. It's my privilege to invite Dr. Rajiv R. and Dr. Tarun Varghese Jacob. Dr. Rajiv R., Assistant Professor, Department of Oral and Maxillofacial Pathology, Government Dental College, Trivandrum. Dr. Tarun Varghese Jacob, Professor, Department of Oral and Maxillofacial Pathology, Sri Shankara Dental College and Research Center, Varkala. We welcome you, sir. Now let's proceed to the instructions. For paper presentation, you have 5 minutes. You will be given 30 seconds for the screen share before presentation. If your time exceeds more than 30 seconds, next candidate will be called off and you will be given a chance at the end. You will be given a warning at 4th minute and proceed by final warning at 5th minute. I hope the instructions are clear. Now let's start the session. I would like to call PG paper 21, PG paper 21.
Yes, ma'am.
Okay. You will be given 30 seconds for the screen sharing. Okay, now start.
Ma'am, is my screen visible, ma'am?
Yeah.
Okay, ma'am. Can I start my presentation?
Your time start now.
Okay. Good afternoon to the respected panel members and the jury. Today I am presenting a pilot study about programmed at ligand 1 expression in OSCC. To the introduction, oral squamous cell carcinoma is prevalent in South Asian countries with the rising cases of its incidence and mortality. Despite of its advancements in treatment, survival and recurrence, but yet the recurrence rate is poor. Various therapies have been included in the treatment of oral squamous cell carcinoma. Recently, immunotherapy is now a novel therapeutic modality in immuno-oncology. And immune checkpoint proteins are under investigation for clinical implications, among which my topic of interest, programmed at ligand 1, has also shown valuable results in certain malignancies such as oral squamous cell carcinoma. The aim and the objective of my study is to evaluate and correlate the expression of programmed at ligand in different grades of oral squamous cell carcinoma by immunohistochemistry. And this I have done to predict the prognosis. And we have compared and evaluated PDL1 expression between different histopathological grades of oral squamous cell carcinoma and compared with the normal tissues by immunohistochemistry. These are my materials and methods, where initially we have taken oral squamous cell carcinoma subjects and an incisional biopsy was done, where the armamentarium for incisional biopsy was shown. Later, the tissue was taken for processing and then sectioning, and his hematoxylin and eosin staining was done. Later, we have done immunohistochemical staining for PDL1 antibody. And these are my antibodies which I have used, and these are my secondary antibodies used. Later, we tabulated the results and the statistics were done. These are few pictures of my cases where we have seen PDL1 expression. This is the first 3 pictures. They show this is a H&E picture of PDL1 expression, and this is the H&E picture of well-differentiated oral squamous cell carcinoma, and this is a picture showing PDL1 expression in well-differentiated OSCC cases. This is a picture of moderately differentiated, and these are the pictures of IHC of moderately differentiated OSCC. And this is a picture of poorly differentiated, and these are the pictures of IHC in poorly differentiated. When we have observed in different histopathological grading, we have seen an overexpression of PDL1 antibody in the poorly differentiated grade when compared to moderately and well, where in well there was a very little expression, and moderately there was mild to moderate staining, and in poorly there was strong staining. We have correlated various other parameters like gender, age, and all, but we have seen a clinical significance with a p-value of 0.001 in staining intensity and staining distribution, where we have calculated the staining intensity based on scoring 0, 1, 2, 3, 1, 2, 3, where we have given 0 for no staining, or where the intensity was less than 5% of the cells, and one is for mild, where the intensity was from
Madam,
5.
you have an additional minute.
Yes, sir. Okay. 5 to 30 and 60 to 30%, and 3 is 60 to 100%, and we have seen an increased staining distribution in poorly differentiated grade. Coming to my summary and conclusion, oral squamous cell carcinoma, it is heavily the formation and progression is heavily reliant on the immune system, and numerous mechanisms on tumor escape have been identified. And there is a release of immunosuppressive mediators and alterations in lymphocyte function. And recent advances have shown involving immune checkpoint have significantly altered the practice of clinical oncology, and cytotoxic T cells are inhibited by signal of PD-1 activation. There are a number of cancers which showed PD-L1 expression elevated in PD-L1 and PD-L2, and the expression of this in the cancer cells has been linked to defending against the particular immunological response.
Madam, time is over.
1 minute, sir, my last slide. There is an overexpression of PD-L1 in.
To be fair, the time has been over.
Okay, okay, sir.
Sorry. Now we shall continue.
Thank you, ma'am.
Okay.
Okay, now it's time for the discussion. Over to you, sir, Dr. Rajiv R. Sir. Now it's time for the discussion. Over to you, sir, Dr. Rajiv R.
Madam, is it fine if you can stop the screen share, please?
Okay.
Sir, it's time for the discussion. Now over to you, sir, Dr. Rajiv R.
Rajesh sir, are you present? Could you please share the screen? Okay, we shall move on. Now over to you, Dr. Tarun Varghese Jacob, sir.
So it was a very good presentation, and the slides were also, the photographs also were very clear. It's actually a huge topic, but she was able to comprise it at a very short moment's notice. Well done, Dr. Leela.
Thank you, sir.
Yeah. What made you choose this specific ligand? Is there any particular reason or any specificity for oral cancer?
Sir, yes, sir. In oral cancer, we can use this as a prognostic biomarker for the detection of survival rate
No, this specific ligand. There were others like trail and all, no?
Yes, sir. Yes, sir.
Now, why did you choose PDL1? Any, combined specificity or any particular reason?
Sir, because I have done this study to check if this PDL1 it blocks the activation of T cells and exhausts the T cells. Sir. So I wanted to know if it is only seen in OSCC or even it is expressed in the normal cases also.
Okay.
The lymphocytic proliferation and activation.
No, I mean, is there any specific weightage or this ligand over other ligands? Do you have any information on that?
Sir, recently this has now been used as a target therapy, so I thought we should. There is a very little literature about this ligand recent days. Only a few of the studies were done. So
Yeah,
I have choose this topic to make. Actually, this is a pilot study, sir. I wanted to do it in a large scale, so I have done.
Okay, fine. Because what I was planning to know is whether this specific ligand was chosen over any specific gene therapies or any therapeutic protocols. Have you any information on that?
No, sir. Actually, this has been used as a therapeutic target therapy. These days, I mean, there is a literature written, and there are researches going on regarding this, sir. So I have done this in a very small, in a limited sample size of 60, sir. So I wanted to do it, check if.
The sample size is 60, huh? Okay.
Yes, sir. Yes, sir.
All right. Okay, great. Thank you, Lina.
Okay, thank you, sir.
Thank you, sir. Next, I would like to call PG paper 22.
Good afternoon, ma'am.
You can start now.
Can I start?
Yeah.
Good afternoon, all. Today I will be presenting a case report of a locally aggressive rare variant tumor of posterior jaw. A 72-year-old female patient reported with a complaint of swelling in the right lower back tooth region since 1 year, which was slow growing and gradually attained the present size, and it was painless also. On extraoral examination, there was a slight on the right of the face, and diffuse swelling is seen on the right side of posterior body of mandible. On intraoral examination, diffuse swelling of about 7 to 8 centimeter in size, extending from 4.3 to 4.6 region, and the labial vestibule was obliterated and the overlying mucosa is blanched. On palpation, it was bony hard, non-fluctuant, non-tender swelling with buccal cortical expansion. For radiographic examination, both OPG and CBCT were taken. The radiograph was peculiarly distinct, where one area shows complete unilocular radiolucency was present in symphysis region, and from 4.3 to 4.6 region, mixed radiolucent and radiopaque in appearance. And the most posterior area, especially in the 4.7 to 4.8 region, the radiolucency was more compared to the mid portion of the lesion. Based on clinical and radiological features, it was provisionally diagnosed as fibro-osseous lesion. An incisional biopsy of the lesion was done, and we received 4 bits of formalin-fixed soft tissue specimen. Largest bit measures 1.1 into 1.1 into 0.4 centimeter, and the smallest bit measures this much, and the grayish white in color, and it was firm in consistency. On histopathological examination, the tissue section shows cystic lumen and the underlying fibrous connective tissue, fibrovascular connective tissue. The connective tissue shows islands and follicles of odontogenic epithelium. Here also we can see the islands and follicles of ameloblastic epithelium within a fibrous connective tissue. The island shows several tall columnar cells with palisaded nuclei and central state reticulum-like cells. Based on clinical, radiographic, and histopathological examination of incisional biopsy, it was diagnosed as ameloblastoma. And these are some of the pictures taken during surgical management. Hemimandibulectomy followed by reconstruction done in this case. In the excisional biopsy, we received 3 bottles. Bottle 1, cystic cavity. Bottle 2 include gland with node. Bottle 3 include hemimandibulectomy specimen. On histopathological examination of the excisional biopsy specimen, a few compressed strands and cords of odontogenic epithelium like animal pattern within the hyalinized connective tissue noted on some area. It was the suggestive of desmoplastic variant in some areas. One shows islands of odontogenic epithelium, central hyperchromatic spindle-shaped cells, and peripheral cuboidal cells. Focal clear cells change also noted within the follicle. The connective tissue surrounding the tumor island is densely collagenous, and area of hyalinization also seen. Since both the desmoplastic and the follicular patterns are present, the excisional biopsy confirmed it as a hybrid ameloblastoma. Ameloblastoma is a common odontogenic tumor, accounting for around 18% of all odontogenic tumors. Follicular and plexiform are the most common histologic variant, while desmoplastic is extremely rare, and it is an uncommon benign locally infiltrative type of ameloblastoma. The present case showed microscopic features of both desmoplastic and classical follicular ameloblastoma, and it is named as the hybrid ameloblastoma. It is a rare variant, extremely rare tumor variant in which both histologically areas of both follicular or plexiform coexist with areas characteristics of desmoameloblastoma. The cause for this peculiar histologic appearance is still unclear. Radiographically, in our case, it mimics fibro-osseous disease. Hybrid variant appears as mixed radiolucent and radioopaque lesions with irregular borders and similar to common radiological pattern observed in desmoplastic variant or lesions. Although clinical and radiographical features are almost the same in hybrid type, only histopathological features are distinctive from each other, which help in achieving a definite diagnosis. It is much too early to speculate whether desmoplastic changes occur secondly in the stroma of a pre-existing solid or multicystic ameloblastoma, or whether areas of primary desmoplastic ameloblastomas transform into a solid or multicystic ameloblastoma. Thank you.
Thank you, ma'am. Now it's time for the discussion. Over to you, sir, Dr. Rajiva.
Am I audible?
Yes,
Yeah.
sir.
Okay. It was a very nice presentation. What about the prognosis of this condition when compared to the conventional ameloblastoma?
Patient is under follow-up, sir, and he's fine.
As
He's
per
fine.
literature.
Yes, sir.
As per literature.
As per literature, the hybrid ameloblastoma is extremely rare, and the recurrence rate is very high than other variants.
Even when compared to the desmoplastic variant.
No, sir. Desmoplastic variant is more recurrence rate is high in desmoplastic variant than hybrid ameloblastoma.
Okay, whether you have published it? Or...
No, sir. No, not yet.
Okay. Thank you.
Thank you, sir. Now over to you, Dr. Tarun Varghese. Sir.
Yes, it's a very good presentation. You have finished it on time. Could you please go back to the histopathology slide? Histopathology slide, yeah. Okay, how are these sections, how are the gross specimens received? Would you?
Sir, the excisional biopsy we received as in 3 bottles. Bottle 1 contains cystic cavity, and the bottle 2 includes gland with node, and the bottle 3 semi-endometrium specimen.
Okay, here you can see some in that 40x magnification. Okay, yeah, thank you. Could you go back to the histopathology slide?
So here?
No, the histopath, your slides. Tissue slides. Yeah. In the 40x magnification, can you see some nerve-like bundles there?
Nerve bundles?
Yeah.
So, no, not nerve-like, not bundles. So, animal-like desire pattern of odontogenic epithelium.
Okay. I thought it was really nerves. Okay. All right. So, what about the third specimen? That third gross specimen you got? How was it looking like? Can you go back to that gross specimen?
Sir, the semi-mandibular fin is
Okay, so
it was like chocolate or perforated chocolate like exudation was there.
have you mentioned that here in the slide?
No, sir, I didn't mention.
Okay, it would be more specific when you do that because because since the literature is a little bit lacking on that, your findings could be more helpful.
Okay, sir.
Okay, good. Anyway,
Okay,
good. You finished on time. Your slides are very clear and they're all well aligned. Okay, good presentation. Well done.
Thank you, sir.
Yeah.
Thank
Okay.
you so much.
Thank you.
Thank you, sir. Now I would like to call PG paper 23.
Hello, I'm audible.
Yeah. Your time start now. Oh.
Sorry,
So,
madam. Could you please present your screen?
Is my PPT visible?
Yes, madam, it is.
Okay. Good afternoon. My topic of presentation is basal cell adenoma of sublingual gland, report of a rarity at a rare site. Basal cell adenoma is a benign salivary gland tumor composed of nests and coats of small basaloid cells with inner ductal epithelial cells. It was first described by Klein-Esser and Klein in 1967. Basal cell adenoma accounts for only 1 to 3.7% of all salivary gland tumors. It was included in the group of monomorphic adenomas along with canalicular adenoma in 1991 WHO classification as a separate entity. Most frequent location of this tumor is parotid gland, accounting for only about 80% of cases, followed by submandibular gland, followed by intraoral locations. In this report, we represent a case of basal cell adenoma of sublingual salivary gland. In literature, there have been only 3 cases of sublingual salivary gland with basal cell adenoma. To the best of our knowledge, this is the 4th case. A 40-year-old female patient reported to our institution with a chief complaint of a painless swelling in the mouth since 4 months. Intraoral examination revealed moderately firm, well-defined overt, solitary, basilated swelling in the left sublingual region, measuring approximately 3 into 2 centimeters. No visible pulsation or pus discharge was noted. No swelling was mobile on bimanual palpation. USG revealed a well-defined hypoechoic lesion noted on the floor of the mouth towards the left side. Internal vascularity noted. No calcification seen. Inferiorly, the lesion is related to mylohyoid muscle, anteriorly to mandible and superiorly to buccal mucosa. FNEC showed a small cell neoplasm of sublingual salivary gland favoring basal cell adenoma or monomorphic adenoma. Excision biopsy was done and the gross specimen was a circumscribed round mass of tissue with nodular projections on the surface. Histopathology revealed a single bit of tissue covered by a fibrous connective tissue capsule. The tumor cells was arranged as islands showing basis squamous whorling and as broad cords. Islands are separated from others by connective tissue. At one end, cribrified RBCs and pooled mucin. IFC was done and showed strongly positivity, scalp positivity, monomorphic basaloid cells without a chondromyxoid component, other names being monomorphic adenoma and basaloid salivary gland adenoma. Membranous variant is also called dermal envelope tumor. It is extremely rare and it can be solitary or part of Brooks-Spiegler syndrome. CTNNB1 mutations were associated with tubular trabecular pattern and CYLD1 mutations associated with Brooks-Spiegler syndrome. 2 hypotheses for the pathophysiology have been given: intercalated duct or reserve cell origin or basal cells of epithelium of pleomorphic adenoma showing transdifferentiation forming predominantly basaloid cell population. Peak incidence in 5th to 7th decade of life with marked female predilection, rarely occurring congenitally and resembling embryoma. So in our case, this is a 40-year-old female patient. Clinical presentation of BCA is a slow-growing asymptomatic form, freely mobile swelling of size less than 3 cm, which is concurrent to our case. Histopathologically, 2 types of tumor cells are described, that is basaloid cells with basal or bioepithelial phenotype and luminal cells, fibrocellular stroma and cystic formation, occasionally acinar cells, squamous whorls or keratinization. Six subtypes have been described: solid, tubular, trabecular, membranous, which are common; stromal, rich, and cribriform, not that common; solid pattern with predominantly basaloid cells in the form of solid
Madam,
mass.
you have an additional minute.
Trabecular pattern with interconnected narrow trabeculae, tubular pattern with numerous tubules, and central lumen; membranous type with the eosinophilic hyaline membrane. Now, IHC was found to be positive in literature for cytokeratin, EMA, CD117, calponin, S100, and P63. DD, adenoid cystic carcinoma, and basal cell adenocarcinoma was excluded because it was encapsulated, lack of infiltrating growth pattern or perineural invasion in adenoid cystic carcinoma, which is not seen here. Also, basis squamous swelling, which is absent in ACC. Now, pleomorphic adenoma was excluded because of lack of chondromyxoid stroma. Also, sharp distinction between epithelial and stromal components is seen in basal cell adenoma, which was not in pleomorphic adenoma, and canalicular adenoma was excluded due to lack of double column of cells. Now, treatment: these tumors are amenable for conservative treatment like excision. A tumor has a low recurrent rates. Only malignant transformation 4% found in literature in membranous type. Now, basal cell adenoma of sublingual gland is rare occurrence. In this case, DDs was pleomorphic adenoma and adenoid cystic carcinoma. Histopathological examination of mnemonic and immunohistochemical findings were confirmatory in this case.
Madam, your time has been.
The time is up. Thank you, ma'am. Now it's time for the discussion. Over to you, sir, Dr. Rajiv.
Yes. Am I audible?
Yes, sir.
Okay. It was a nice presentation. So why it is considered rare in that particular gland?
It is very rare, sir, because in minor salivary glands, especially intraoral minor salivary and basal cell adenoma, cases have been reported only up to 3 cases in literature. To the best of our knowledge, this is the 4th case. Mainly it is in the parotid gland and submandibular salivary gland.
So it's usually in major glands only.
Yes, sir.
So what about the histogenesis of this neoplasm?
It is found to be associated with the ductal reserve cells, intercalated ductal reserve cells in the literature, in the textbooks, and also another pathophysiology, that is basal cells of pleomorphic adenoma undergoing epithelial mesenchymal transformation, and it predominates the basal cells, and that is also found to be a pathophysiology for the histogenesis.
What's the most important histologic DD for this case, for your case? Histopathology.
Pleomorphic adenoma is the most major DD.
What about your case?
In our case, we can say pleomorphic adenoma or canalicular adenoma.
Was it a straightforward diagnosis of your this?
Actually, the histopathology was very pathognomonic. We didn't have much confusion, and IHC was confirmatory.
Okay. Thank you.
Thank you, sir.
Thank you, sir. Now over to you, Dr. Tharun Varghese Jacob, sir.
Doctor, it was actually for me it was a rare thing, was presentation.
Yes.
And, what about the prognosis?
Prognosis is good, sir. Recurrence rate is very less. Malignant transformation is also very less. Only around 4% malignant transformation has been found, especially in membranous type.
Okay, what are the IHC markers used?
We used cytokeratin, pan-CK, CD117, and calponin.
Have you shown those slides here during your
Yes, sir. Yes, sir. I have shown.
Okay, okay. Thank you. Thank you.
Thank you, sir.
Thank you, sir. I would like to call PG paper 24. Okay.
Shall I start?
Yes.
Time starts now.
Shall I start?
Yes. Your time start now.
Oh, okay. Today I'm here to present a case report on recurrent swelling in anterior maxilla. A female patient of 40-year-old presented with chief complaint of pain and swelling in the left upper jaw since 1 year, associated with headache, intermittent ear pain, and she also gives a history of similar lesion on same side, which is treated few years back. Diffuse swelling noted on the left side of the face and the mild asymmetry of the face and obliteration of the nasolabial fold also noted. On intraoral examination, bony heart swelling extending from distal border of 2,4 to mesial border of 2,1 is seen, and the size is about 5 into 2 centimeter, and it was firm in consistency, slightly tender, and obliteration of labial vestibule also noted. And the swelling also seen extending to the palatal aspect as a well-defined round swelling. Mild palatal expansion is seen, and the swelling is of size 1 into 1 centimeter, which was hard to form in consistency. Based on clinical findings, we arrive at a clinical differential diagnosis as odontogenic cyst, odontogenic tumors, or bone tumor. Then investigations include routine blood examination, radiological examination, and biopsy. On radiological investigation, frequency extending from mesial aspect of root of 1,1 to mesial aspect of root of 2,4 with a well-defined border. The resorption of root is seen in 2,1, 2,2, and 2,3, mesially tilted 2,3, and multiple impacted and retained teeth also noted. And the CBCT shows a bony lytic lesion involving the alveolar and palatine process of maxilla from 1,1 to 1,4, and there were bony erosions. We see cause the expansion of lingual cortical plates, and in this image we can see the bony expansion and the soft tissue opacity in the left maxillary sinus. And we received the incisional biopsy of the format soft tissue specimen, which is whitish in color and firm in consistency, and the tissue was varied in sizes, and histopathological diagnosis was neoplasm. And the surgical incision is done for the same. And these are the biopsies received after excision. We received 5 format specimen, 4 bottles of soft tissue specimen, and 1 bottle of hard tissue specimen, and the tissues were sent for processing. On histopathological examination, alternate hypercellular and hypocellular areas are seen, that is atony A and atony B. Hypercellular areas which include spindle to oval shells, vague nuclei palisading around the eosinophilic areas, that is Verroque bodies. Hypocellular areas are delicately collagenous and irregularly spindle cells were seen. In this section, we could see the atypical cells with hyperchromatic nuclei and the multinucleated giant cells also seen. And there we can also see the areas of hemorrhage and hypothermia. For confirmation, clinical investigation is done. Which was positive and showed brown staining for all neural cells, which confirmed the cell. And radiological, histopathological, immunohistochemical arrive at a final diagnosis as recurrent maxillary schwannoma. And these were the follow-up pics of the patient after 2 weeks, and the post-operative healing was satisfactory. Coming to the discussion, schwannomas slowly solitary tumors originating from schwannomas in the ventral nerve sheath. Approximately 25 to 40% of the cases are seen in head and neck region, of which only 1% in the oral cavity. The tumor can originate from a myelinated central or peripheral nerve with schwannomas, and the schwannomas are solitary in 90% of cases.
Madam, we have an
Schwannomas
additional
are encapsulated with biphasic patterns. Interosseous schwannomas involving maxilla is extremely rare, and the recurrence is extremely rare. In our case, schwannomas was locally aggressive, causing bone loss, and was recurrent. These are my references. Thank you.
Okay, thank you, ma'am. Now it's time for the discussion. Over to you, Sir Dr. Rajiva.
Yes, am I audible?
Yes, sir.
Yes. So, in your histopathology, certain giant cells were there, isn't it?
Yes, sir.
What are they actually? What is the significance of these giant cells in your lesion?
Giant cells is the typical feature of a schwannoma, and it's a typical feature of a schwannoma.
No. What are the typical features of a schwannoma? Histopathology.
Atony A and atony B bodies were seen, Verroque bodies,
Okay. So where does this giant cells come from?
So, so while we rule out in histopathology, we could see the giant cells.
Okay. It was an intrabony lesion, isn't it?
Yes, it's an intrabony lesion. It was extremely rare.
Okay.
In case of schwannoma.
Okay, that I accept. So what is the lineage of this giant cells there in your lesion, this particular lesion?
Sir, sorry, sir.
So in a soft tissue schwannoma, we are not
Dr.
expected.
Ammo, kindly
Hello.
go to the histopathological session slide.
So here's the histopathology.
Okay. So the typical features of schwannoma, you could able to. Okay, that is there. Okay, that's why you have made the diagnosis of a schwannoma. Okay. Then, okay. Apart from that particular pathognomonic features, you can see certain giant cells, isn't it?
Yes, sir.
Okay. So is it a common feature of a schwannoma?
No, sir. It's very rare.
Okay. Okay, leave it. Okay. So what about the prognosis? You are still following it up, isn't it? This particular
Sorry,
case.
sir.
What about the prognosis of this case? Actually,
Actually, the healing was satisfactory.
Okay.
Prognosis is good.
Okay. Is there any chance for malignant transformation in a schwannoma?
Schwannomas turning into malignancy is very rare. Mostly benign lesion is seen. Here, there are very few atypical cells seen. So we didn't consider as a malignancy. We didn't find. We couldn't find a considerable amount of atypical cells.
Okay. I'm not asking about this particular case. So what do you call a lesion which is turning into a malignant one of this nerve sheath origin?
Sir, sorry, sir.
What do you
Malignancy.
call the malignant counterpart of this lesion, this particular benign lesion? What is the malignancy named as?
Malignant schwannoma.
No. Okay. Over to Dr. Tarun.
Yeah, Dr. Ammo, it is a good presentation, see, even have you shown the IHC slides here? Were you able to do some IHC investigations?
Yes, sir. Yes, sir.
Yeah, no. Have you shown it here in your presentation today?
Yes, sir.
Could you show me the slides? I was not able to see it since you went past. What are the markers used?
Sir, S100.
Okay, great. So when you got the gross specimen, how was it?
So we received 2 bottles of specimen. Sorry, 4 bottles.
Yeah, I saw that. But what are the features you were able to appreciate? Was it did it have any specific consistency or something like that?
So we often consistency.
Okay, then. Were the teeth mobile in the patient?
Yes, teeth were mobile.
Okay, but I don't think you have mentioned there, no?
No, sir, I didn't mention.
Yeah, you say all the clinical features, no, it should be intact when you all specify this in your presentation, no? Because it will be helpful when you're.
There were root resorption also.
Okay, fine. One more thing is, have you published this article?
No, sir.
Not yet. Okay, fine. So you must, specify all these things. It really looks good. Okay.
Okay, sir.
Okay, thank you.
Thanks.
Okay, thank you, judges. Now I'd like to call PG paper 25.
Good afternoon, ma'am. Am I audible?
Yes. Your time start now.
Yes. Good afternoon, ma'am. Today, I am presenting a review titled as Role of Trace Elements in Oral Squamous Cell Carcinoma, Current Perspective. These are my contents. So, as you all know, oral cancer is the most widespread type of cancer globally, and it is ranked 6th in terms of occurrence. The cause of oral cancer are tobacco, alcohol, and other carcinogenic products. It is most commonly seen in South and Southeast Asia, also Central and Eastern Europe. Due to increased awareness among healthcare providers and the general public, a considerable number of patients are now diagnosed with the disease at earlier stages. Epidemiological research suggests that intervening in the early stages of oral carcinoma can reduce the number of deaths related to the disease. Recent advances in the clinical, histological, and molecular immunological markers have replaced the era of uncertain investigations into the cause of cancer. Improved survivorship and higher quality of life can be achieved through the implementation of multidisciplinary treatment programs and early detection, which can significantly reduce the mortality rates. Now, trace elements are the elements which are found in small, imprecise amounts in living organisms. For example, zinc, copper, selenium, chromium, cobalt, iodine, manganese, and molybdenum. Now, the basic role of trace elements in body, it is required in very small quantities for normal physiological function. It accounts for 0.02% of total body weight, and they play a significant role. For example, active centers of enzymes or as a trace bioactive substances. Deficiency causes reduced activity of the concerned enzymes. As each trace element is related to so many enzymes, deficiency of a single trace element is often not associated with any specific clinical manifestations, but rather manifests as a combination of various symptoms. Now, here is physiological functions of the trace elements with their normal values. Like iron, it helps in the production of hemoglobin. Zinc helps in enzyme functions like metabolism of proteins, carbohydrate, and lipids. Copper helps in the formation of RBCs and for the proper immune functions. Iodine is required to produce thyroid hormones, which regulate the metabolism, and chromium helps in glucose metabolism and insulin signaling. Now, why important to analyze the trace element? Because research has suggested that some trace element deficiencies may contribute to various health issues such as cancer, atherosclerosis, developmental delays, and abnormal pregnancies and lifestyle-related diseases. Atomic absorption spectroscopy measures the trace elements accurately, determine their functions, and understand the characteristics of their deficiency and excess states. Therefore, proactive medicine is focusing on the study, survey, and prevention of trace element deficiency. This is the review of literature. According to Chang et al., low levels of zinc were associated with increased risk of OSCC. Elevated level of copper associated with increased risk of oral cancer given by Su et al. Iron accumulation has been reported in oral cancer, and is it implicated in its progression given by Sharma et al. Increased level of manganese is found in oral cancer tissues by Sharma et al. Chromium plays a role in the development of oral cancer given by Vaidya et al. Also, trace element play a role in the cancer treatment as well as prognosis. Given for an example, zinc has a protective effect against the development of OSCC, and it acts as a potential biomarker for diagnosis given by Alam et al. And Scully et al. Selenium acts as a potential chemopreventive effect against OSCC. Also, selenium supplementation may improve the outcomes in cancer patients. Copper play a role in the growth and proliferation of cancer cells, and copper-lowering drugs may be a potential treatment option for OSCC. Iron plays a role in the growth and division of cells, and iron overload may be a risk factor for OSCC. So, in conclusion, trace elements play an important role in the body as component of enzyme or as a part of enzymatic reaction. In certain cases, like OSCC, trace elements in serum can help in early diagnosis, appropriate treatment, and indicators of prognosis as the disease progresses. Hence, trace elements can be considered as a biomarker for OSCC. Also, with any medical treatment, it is important to consult with healthcare professional before making any changes to your diet or supplement regimen, as by increasing or decreasing certain trace element in your diet can have protective or harmful effect on cancerous cells suggested by different studies done. These are my references. Thank you.
Thank you, ma'am. Now it's time for the discussion. Over to you. So, Dr. Rajiv, sir.
Yes. Am I audible?
Yes,
sir.
Okay. So it's a review, in fact. Your references actually, they were actually a narrative reference or based on any systematic review or meta-analysis or something like that?
No, some are reviews and some are studies.
Studies means which type? Are they trials or
Sir, original study.
No. Are they trials like RCT, randomized controlled trial or something like that?
Sir, some are observational studies like the serum levels of certain stress element in oral cancer and potentially malignant disorders in normal individuals. They have compared values of stress elements. Like
observational studies, like in an empirical manner only, they have some role, isn't it?
Yes.
Is there any significance related to the chemo prevention strategy that we are adopting for this oral potentially malignant disorder?
No, sir.
So are they the same or
Girjati.
the role of these or any nutritional supplements or something like that, is it useful once a well-established squamous cell carcinoma is there?
Yes, sir. It is used in the treatment planning also. Can give the supplement of trace element during the treatment of the cancer patient. And it can help also in the prognosis as the disease progresses, the values of trace elements, there is alteration of the value of trace elements.
So that is due to the treatment, or is it due to the supplementation?
Yes, sir.
Or both?
Yes, sir. It is there is the role of trace element is in pathogenesis of cancer, also the treatment and the prognosis of the cancer.
No. There is no role in treatment as such actually. Okay, you can supplement with these things, and you can monitor its level in serum and all, whether the patient is improving regarding to the actual modality of treatment. And moreover, it may have certain role in chemo prevention of this potentially malignant disorders that is aimed at prevention of the malignant or delaying, or you can alter the progression in that precursor stage. Once it is an established malignancy, what is its role? That I don't know. Okay. Anyway, thank you. Over to Dr. Tarun.
Thank you, sir.
Doctor, actually, this article which you have been selected for this particular presentation, no, it is actually vague. In fact, you have not specified the pathogenicity of the trace elements. Just, you have just selected the conclusions and just presented, What we would like to do next time when you present a review article is, based on the particular, that the modulatory protocols or the therapeutic instances, it would have been more, substantial in your presentation. And that is also what sir was also asking about. I have also my doubts on manganese because in one of the slides you said increased amount of manganese leads to, there is a severity of oral cancer, elevated, yeah. But it isn't, in the recent articles, there are some disparities regarding this. So I would like you to clarify on that also. Just my doubts, okay?
Okay, sir.
Okay. And, In fact, the high levels of zinc also, in fact, has a beneficial property to oral cancer, because especially in leukoplakia and oral submucous fibrosis, they say zinc is the zinc essentiality is very strong there. But here I mentioned low levels of zinc with an increased risk to oral cancer. So my doubts there as well. Okay, so in the review articles, better be confident on your the usage of the conclusions as well as the particular discussions which are involved in the relevant articles. Okay.
Okay.
Yeah. Thank you. All the best.
Thanks.
Thank you, judges. And I would like to call PG paper 26. Presenter, can you switch on the camera?
Am I audible?
Yes.
Can I start the presentation?
Okay, your start now. The time starts now.
Yeah. Good afternoon, everyone. Today I'll be presenting a case report based on a rare yet a sizable lesion. A 65-year-old female patient complained of swelling in the right middle third of the face since 3 years. The swelling extended superior inferiorly from the inferior border of the eye till the upper lip, and anterior posteriorly from the area of the nose till 4 centimeters approximately anterior to the tragus of the ear. Intraoral examination also revealed a bilateral swelling that expanded buccally as well as palatally, and there was obliteration of the buccal vestibule as well, and missing 1.3 to 1.7 was seen. The swelling intraorally had normal mucosa, there was no tenderness, and the swelling was bony hard. Radiographic examination revealed a well-defined uniform unilocular radiolucency with a thin sclerotic border, and as you can see, the arrow is marked. 1.3 was impacted, and the radiolucency extended from the coronal aspect of 1.3 till that of the mesial aspect of 1.8. Now, considering these two findings, considering the two examinations, we came to the clinical diagnosis of dendritic ameloblastoma, CEOT, and AOT. These were the gross pathologies that were received from the institutional batch. We received 17 specimens, soft tissue specimens, the largest being 1.2 by 0.6 by 0.2 centimeters. This is the stereo microscopic picture of the same, the largest bit. And histopathological examination at scanning view revealed islands of odontogenic epithelial cells with pale eosinophilic homogeneous material surrounding it. And as you can see here, there were also some pale eosinophilic globular masses that were surrounded by the odontogenic epithelial cells at a higher magnification. So, based on that, we gave it a cell tumor and calcifying epithelial odontogenic cells. To go ahead with the final diagnosis, we went with the special stains. Trichrome revealed a blue color blue homogeneous material, as well as in you can see the homogeneous eosinophilic materials actually took yellow color. So based on these two findings, we gave a giving the final diagnosis, since the lesion was large, once more to see if there was any cell. So the final diagnosis was tentinogenic. The patient underwent surgical resection of the, and then we received the largest measure Am I audible?
Yes, sir.
Okay. So the treatment we did was surgical resection of the tumor, and these were the gross specimens or the pathology specimens that we received. The cut section of the same,
Okay, one more
zero
minute, sir.
microscopic view of the same, and finally histopathologically also we found out that has screen sharing. Hello.
Yes, Dr. Nina, please continue.
Histopathology examination also revealed odontogenic epithelial islands that were surrounded by pale eosinophilic material. And again, we went ahead with special stains, that is with Van Riesen, showing a pale yellow eosinophilic, yellow material, as well as with the cells containing pink in color. And also Mason trichrome showed the similar kind of findings that
Sir,
were
your
seen
time
with
is up.
transitional biopsy
Sir,
as well.
your time is
So
up.
it confirmed our previous final diagnosis of dendrinogenic host cell.
Yes, sir.
This DGCT is a solid variant constituting about. Yeah, sure. Yeah.
Okay, thank you, sir. Now it's time for the discussion. Over to you, sir, Dr. Raju, sir.
Okay. Am I audible? Hello.
Yes, sir. Yes, sir.
Okay. Okay. That's a nice case, even though you couldn't complete it. According to the latest WHO classification, what about the status of this lesion?
As per the latest WHO classification of 2022, it is similar, sir, to that of the 2017 classification, sir.
Okay. So, what is the malignant counterpart of this lesion?
It is, sir, host cell odontogenic carcinoma, sir.
Okay. Thank you for this wonderful case presentation. Over to you, Doctor.
Thank you.
Okay, doctor, well presented. Actually, the photographs were good, but even though you had to rush a little bit, it was actually well presented. Thank you for the presentation.
Thank you, sir.
Okay, thank you, sir. Now I would like to cover PG paper 28.
Ma'am, 27?
27.
Yeah. Just one, ma'am. Ma'am, is my screen visible? No.
Not yet.
Now is it visible now?
Not yet.
Okay. Actually, my is it now? Now?
It's coming, but not your presentation yet.
Just write down.
Yeah, it has come, but yeah.
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 Yes.
So, can I start now?
Can you switch on the camera?
Okay. Yeah.
Is it okay? Okay. Yeah. So now I'll share my screen. Okay. Your time start now. Yeah, it's not loading. Yeah. Good afternoon, one and all. My topic is ameloblastoma, an array of institutional cases. Ameloblastoma is an adequate benign orogenic tumor of jaw arising from the residual epithelium of the tooth jaw. Clinically appears as an aggressive lesion. Represent and asymptomatic and slow growing, representing 1% of the oral tumor. Globally, 0.92 per million persons per year are affected. But in India, hello? Yeah, ma'am. Am I audible? Hello? Yes. Continue. Yeah. But in India, it is the most common with prevalence rate of 14.02% to 71.4% with male predominance. Its pathogenesis is multifactorial and involves numerous cellular pathways. Molecular and gene alteration affect development, progression, and characteristics of the lesion. So proper understanding of the pathogenic mechanism is important for molecular targeted therapeutic approaches. In 2022 WHO classification, it is included in the benign epithelial odontogenic tumor. These three clinical types are used primarily. So we present to you a series of histopathological cases of ameloblastoma that were diagnosed through biopsies, and these are the few amongst them. We retrospectively evaluated 64 histopathological cases of 12-year record according to WHO 2022 WHO essential diagnostic criteria. So in this, we found we have 29 excisional and 35 incisional biopsies which were used, and we found out that most patients were between the age group of 16 to 40 years, showing male predominance and posterior mandible as most common affected site. Cases were further categorized as unicystic, peripheral, conventional, etc. Coming to the discussion, our institutional findings were found in accordance with the results of the systematic review and meta-analysis of the studies globally and for the India. I would like to highlight that through the knowledge of biological behavior of various clinical types of ameloblastoma provides an aid in its treatment planning. For instance, in case of multicystic ameloblastoma, since growth rate is slow, any occurrence with the it will probably take some time before becoming evident. And unfortunately, as years pass by, greater chances of patients being lost to follow-up occurs. However, recurrence rate of ameloblastoma is 23.5%, and main factors for recurrence is, however, multilocular ameloblastomas, follicular histopathology, and conservative treatment. Malignant transformation of it is rare, but cases are reported for mandibular location. In the end, I would like to conclude by saying it is essential to accurately diagnose the ameloblastoma histologically from a biopsy so that the chances of recurrence are minimized. Also, prolonged follow-up period should be emphasized to patient considering the high recurrence rate and slow rate of growth properties of the ameloblastoma. Thank you. Okay, thank you, ma'am. Now it's time for the discussion. Over to Dr. Rajiv Vasu.
Okay. It was a nice study of your cases reported in your institution. So, which was the commonest variant? Which was the commonest histologic variant noticed in your study?
So we found out conventional ameloblastoma as the common variant. In that, follicular and plexiform were the common, followed by unicystic.
Follicular and plexiform.
Unicystic form.
Was there any cases of desmoplastic ameloblastoma?
Yes. There were cases of desmoplastic. There were only 3 cases of desmoplastic, sir, amongst all 64 cases.
You have the follow-up data of all these cases up to.
Unfortunately, sir, this is the limit. That is the limitation of this study, sir. We don't have a follow-up data
eventually the patient gets lost, the follow-up is not maintained, and then this is actually a limitation of this study.
Okay. Okay. Thank you. All the
Thank
best.
you, sir. Thank you, sir.
Thank you, sir. Over to you, Dr. Tarun Varghese, sir.
Yes, Dr. Mridula, well presented. How many cases were you able to use for the study?
So we included 64 cases that were over the. It is a retrospective study. We have included the cases over the period of 12 years, from 2011 till 2022.
So hereby, with this study, you are validating that the histological is having the upper hand over the immunohistochemical studies of ameloblastoma.
No, I'm not. I'm not stating anything as such, but sir,
because that's what you said in your take-home message.
So I personally felt that a follow-up is a drawback where we are lacking as an Indian, at least, because we tend, for 1 or 2 years, we tend to do a follow-up. Then afterwards, even patient forgets, or patient moves on, or maybe go to the next doctor or something. But then there is lack of follow-up. So the studies what I have seen during making this presentation, they have a lot of follow-up studies also. But in India, I found it a little less. So I felt that should be emphasized, and people should do that.
Have you received your institutional ethics clearance for this study?
So that is in the process, sir.
All right. And for unicystic ameloblastoma, any specific criteria used to diagnose?
Unicystic ameloblastoma, sir, sorry?
Any specific criteria you have used to diagnose histopathology? Text matter.
Sir, yes, sir. See, we have used actually, we have evaluated those cases and using 2022 essential diagnostic criteria, which was proposed by WHO right now. So we use that thing.
You heard of Victor and Gorlins criteria?
Sorry, sir?
So you heard of Victor and Gorlins criteria?
Sorry, sir.
Victor and
No,
Gorlins criteria?
No, sorry, sir.
Okay. No issues. Okay. Thank you.
Yeah. Thank you, sir.
Thank you, sir. Now I would like to call PG paper 28.
Hello.
Hello.
Am I audible?
Yes. Okay, your time starts now.
Thank you.
Can you switch on the camera?
Yes.
Okay.
Good afternoon, everyone. Today I will be presenting a review on laser capture microdissection and in its application in oral squamous cell carcinoma. Oral squamous cell carcinoma, it is being the 8th most common prevalent cancer in the world. It has the incidence of 2 to 10 per 1 lakh population per year. And it has male predilection, which rises in 4th decade and above that. The etiology for this is multifactorial. It may be in the form of tobacco, in the form of smokeless form or smoke form, alcohol, or aracanate chewing, or any nutritional deficiencies, or sustained viral infections. These all can be the etiology of the oral squamous cell carcinoma. Behavioral risk factors and lack of knowledge can also play an important role in this. So in this, there are many technologies which can which are trying to help for early diagnosis of oral squamous cell carcinoma. So among these advances, this LCM is also one of the advances which can help for early detection of oral squamous cell carcinoma, and also can help to find the biomarkers for the same. Laser capture microdissection, it is a contamination-free method of isolating specific single cells or a group of cells which from the wide variety of cells. That is, and whenever there is a heterogeneity of the tissue, we can pick up a particular cell of interest to study some biomarker or any interest, topic of interest, or any lesion of the interest. And this enables us more efficient and accurate downstream microgenomics and applications. This is the setup of LCM, in which it states A is the monitor and B is the supplemental fluorescent unit, which is present along with the microscope, and C will be the digital microscope interface, D will be the joystick, and E will be the LPC unit, that is laser precision cutting, and F will be the laser unit as proper laser unit, G will be the inverted microscope, and H will be the control unit for all of this. So the basic principle of LCM is visualization of the cell. How will we visualize the cell is basically we have to do H&E staining or any immunohistochemical staining before the procedure. So once it is done, we should visualize these cells in the microscope, and we should allow the laser energy to pass through the particular cell, and it will dissect the cell, and these dissected cells, they are collected in a tube or a microtube or any device, and that can be used in different applications like protein analysis, microarrays, gene analysis, or next generation sequencing, or an RT-PCR. So there are three types of LCM systems basically available in the market. They are the infrared LCM and UV LCM and combined infrared and ultraviolet laser system. The infrared LCM, it uses 10 nanometer of wavelength, and it can be used for the tissues which have the smaller thickness, and the UV is used for thicker sections, and both can be used to maintain the architecture of the cell and as well as to cut the thicker sections. So these are the mechanism how it can work. The first one is there are three mechanisms actually. The first one, it will be the polymer membrane where it is attached. The cell which is dissected by the laser energy is attached, and it is carried and it is collected in the tube. The second one is cells are collected by photonic pressure. The pressure, because of this, the cell are dissected.
Okay, and additional 1 minute.
And the third one is the cells are collected by gravitation, and in this case, this slide is inverted. So these in oral squamous cell carcinoma, these are expressed in normal, precancerous, and cancerous oral mucosal epithelial tissues. Biomarkers can be diagnosed, and it is also useful in finding the biomarkers to identify the surgical margins for the surgeons, and it also helps in targeted therapy of cancer patients and to find the markers for micrometastasis in the lymph nodes, and also expression of microRNAs, which is best achieved in NC. So the advantages include it is simply operatable, it is much faster, and cell morphology is almost maintained, and it is contamination free. It has the cells can be easily examined with the system. The disadvantages can be the resolution is less, and the stains which are used sometimes may not be the
your time is up. Okay, thank you, ma'am. Now it's time for the discussion. Over to you, sir. Dr. Rajiv, sir.
Okay, it's a nice topic for presentation.
Thank you, sir.
Okay, so is there any role of this in oral potentially malignant disorders?
Yes, sir, it can be. It can be, sir. So usually, if we have to find any new biomarkers or anything like that, we can isolate the cells literally, sir. So normal epithelial cells can be isolated from the pre-malignant and the malignant, and the assessment of particular biomarker can be done in particular cell types. So this is useful in the pre-cancer.
So it's an evolving thing, isn't it?
Yes,
like
sir.
that. Okay. So very nice to have such a topic for this particular conference. Thank you. All the best.
Thank you, sir.
Now, thank you, sir. Now to you, Dr. Tarun Varghese, sir.
Doctor, it was actually a
Yes,
very
sir.
interesting topic for presentation.
Yes, sir.
Good selection.
Thank you, sir.
Yeah, I would like to ask you two questions. Other
Yes,
than
sir.
oral cancer, can you specify the relevant use of this technology?
Yes, sir. It can be used. Like for example, if we want to segregate the cells in epithelial mesenchymal transition during the tooth development, if we want to know which origin is the cell, we can isolate the cell and we can assess the markers, sir.
No, I was
And for also and other diseases also, it can be used, sir, with the different biomarkers. It is
okay.
not that it is only used in oral squamous cell carcinoma. This was my topic of interest to take squamous cell carcinoma.
Okay. Other than oral cancers or any pathology, can you say it's just, based on your slides, I was just also thinking, it can be definitely used for one particular science. Could you tell that? Have you any idea on that?
Specifically, sir?
Yes, specifically, yeah, it is there in one of your slides. The answer is there. Yeah, I because you have studied gene therapy and DNA analysis, right? So I
Yes,
think
sir.
it has its varied use in forensic sciences.
Yes, sir. Yes,
Yeah,
sir.
yes, and I think I caught one small gist of slide there you mentioned because since you didn't have time in your summary slide, you mentioned that your hematox and eosin slides they don't have any particular they have a disadvantage.
Yes,
Right?
sir. Actually, sir, when it is stained properly, it can alter the genomics, sir. So light stains of hematoxin and eosin is preferable.
No, what I was particularly referring to is your summary slide. If you could just show us that, because I think in this type of procedures you are not able to use a cover slip, right?
Yes, sir. Yes,
If
sir.
I'm-
That is because of that, sir, it is drying out.
Yeah,
So
yeah. The second point, commonly
yes,
used stains, such I mean, sometimes not effective. So then, what are the other stains which is?
sir, other than hematoxin and eosin, we can use immunohistochemical stains, sir. So, but there also we are not using cover slips, sir. This is the major problem, sir, with the LCM.
Okay. So, is there any particular stain they have stated for LCM? Any specific stain which is advantageous?
In all these literatures, they have stated, sir, mainly immunohistochemical stainings only, sir, for that particular cell of interest.
Okay.
Other than that, H&E only I could see.
Okay. Thank you, doctor.
Thank you, sir.
Thank you, sir. I would like to call PG paper 29. Next is PG paper 29. Okay, then I would call the PG paper 30.
Hello,
Hello?
am I audible?
Yes, yes.
Shall I start?
Yeah. Can you on this
Is my screen
camera?
up? Is my screen visible?
No.
1 second. Now is my screen visible?
No, ma'am. Yeah.
Is it
Can you switch
now?
on the camera?
Yeah, 1 second.
Okay.
Fine.
Okay. Your time starts now.
Good afternoon, one and all. Today I'm going to present a study conducted in our institution for evaluating the accuracy and validation of Bedek et al.'s method of age estimation in mixed dentition population in Western India. As we all know, age estimation is an integral part of legal investigations. The need of age estimation arises in various legal cases involving children for civil aspects like adoption, child labor, or criminal proceedings such as rape, kidnapping, illegal immigration. An accurate and dependable age estimation method can aid in narrowing down the list of possible victims. Therefore, adapting an appropriate and accurate age assessment method for any population group in need is vital in forensic practice. Although several parts of the body can be used for age estimation, unlike other skeletal tissues, dental tissues once formed do not undergo significant remodeling after their mineralization is completed and are only slightly affected by aging or alterations in hormones, fire, or chemicals. Literature describes several techniques that address age estimation: biochemical, morphological, and radiological. Of all these, radiographic assessment of age is a simple, non-invasive, and reproducible method that can be employed both on the living as well as dead. Few age estimation methods are Shore and Massler, Gustafsson method, Nola's method, Demirjian's method, Schuler's method, Swall's method, Kamier method, and Bedek et al.'s method. Coming to the aims and objectives, in 2019, Bedek et al. Developed new models of age estimation based on a combination of 1 to 7 mandibular teeth using univariate regression and regression with forward and backward elimination. To date, no method in the literature has been put forth to assess chronological age in living individuals with multiple missing mandibular teeth. Bedek et al. Highlighted the absolute necessity of age estimation methods, particularly in cases of hypodontia or incomplete human remains with multiple missing teeth. This method has not been tested on Indian population with an exception of study conducted in the South Indian population. As there is no evidence of study in the Western Indian population, looking into the accessibility of the population group, the present study aims to evaluate the validity and reliability of the Bedek method in Western Indian population. So the permission to conduct the study was obtained from the Institutional Ethical Review Board. 525 OPGs were of children aged between 5 to 15 years were collected retrospectively from the Department of Oral Medicine and Radiology of our institution. Blinded study was conducted where the radiographs were analyzed by means of ImageJ software independently by the two different investigators. The data was tabulated and subjected to statistical analysis for accuracy of age estimation. Firstly, the developmental stages of 7 left mandibular teeth were determined using the scale introduced by Demirjian, which consisted of 8 different stages from A to H. The data was entered in the Microsoft Excel sheet. Coefficients were assigned gender-wise based on the developmental stages of the teeth and were summed up. The age of each individual was calculated by the formula, which includes dental age is equal to intercept plus coefficient assigned to the tooth stages. So after the statistical analysis, we found out that there was an underestimation by a range of minus 0.75 to minus 1.30. The Pearson correlation R value ranges from 0.84 to 0.9 in females, whereas in males it was between 0.77 to 0.9. If the R square value is more than 0.5, it is considered to be more accurate. In all the models, the R square value was in between 0.7 to 0.9. So it was considered to be the accurate method. So there was an underestimation in all the models with p-value less than 0.005 for all the teeth models except for 3 and T-teeth model. Our results were in collaboration with Croatian population, South Indian population, and the Turkish children. The merits of our study included that this is the only study conducted in Western India for assessing the accuracy of Bedek models, where sample size was considerably high compared to the other available literature. In case of missing teeth, we have got satisfactory results. All the OPGs were digital, standardized, and taken from the same machine. Less literature is available online for the Bedek method. Less number of OPGs were used in institutional level study. The advantages of BEDEC method are that it is simple, reliable, accurate, non-invasive, and it can be used in hypodontia cases. Limitations is that it cannot be used in distracted mandible or distorted OPGs. To conclude with, in our study, we found that accuracy of age estimation increases significantly with the number of teeth used, and 7 to 4 teeth models were the most suitable for age estimation. These are my references. Thank you.
Thank you, ma'am. Now it's time for the discussion. Over to you, Dr. Rajesh, sir.
Okay, thank you. Doctor, it was a very nice presentation, an elaborate one. Was it conducted in your institution by yourself or?
So in our institution and by myself also, and one more PG.
Okay. So in comparison with the Williams method.
Yes,
so
sir.
have you, okay. Why didn't you compare with Williams method instead of Demirjian's?
So actually, Demirjian is, we have not compared with Demirjian's, but it's a part of a BEDEC method only. Firstly, we have to allot the stages of the tooth.
The scoring
according to
system
the-
you have taken from Demirjian's only, isn't it?
Yes, sir.
So original Demirjian's on the French population, that's the score. I mean, the chart you have used, isn't it?
Yes, sir.
Okay. The 17th method, not the modified one, isn't it?
No, sir.
Okay. So what about so one more study you have referred that in South Indian population, okay,
Yes,
isn't
sir.
it? Okay. So have you compared with your data and that particular study?
Yes, sir. Actually, some of the results were comparatively similar to that of the South Indian population study. In South Indian population, they found out that 7 to 4 teeth model and 1 teeth model were more accurate in estimating the age. But in our study, only 7 to 4 teeth model were more accurate, not the 1 tooth model.
Okay. So when comparing with the modified Demirjian's method, what is the
Yes, sir.
advantage this particular technique is having?
So compared to the results of the Demirjian's method are not that accurate in the cases of missing teeth. Like in the cases of hypodontia, this method can be used more accurately to estimate the age, whereas the modified Demirjian's method, we are not able to assess the age that accurately.
Okay, so there we need the full complement
All
of
the
teeth.
teeth should be present
Okay.
of the mandibular third quadrant. Yes, sir.
So okay, similar. So you have done this in mixed dentition, isn't it? Mixed dentition
Yes, sir.
stage.
Mixed dentition population.
Okay. Okay. Similar to like the single tooth radiographic age estimation methods in adults, is there any other methods? If you are getting only 1 or 2 teeth, okay.
Yes, sir.
Can you suggest some radiographic methods like this for adult population also?
Sorry, sir.
Or maybe some histological technique?
Histological cemental annihilations can be done, so.
No. If you are getting only one tooth, okay. For example, one lower canine, permanent mandibular canine, you are retrieving. Okay. Can you use any methods for an age estimation with plus or minus 2 to 3 years of age as a result?
The cemental annihilations, by the help of cemental annihilations, we can assess the age of the patient under light microscope or phase contrast microscope.
No. By using simple radiographic and this image analysis, you can do some other simple age estimation techniques. Maybe histological sections are required, but digital imaging is what is needed. Okay. So what was the role of this image software there in your study?
So basically, to measure the to open the images, we use the software imaging.
Image software, usually we go for some
Measurements and
photography.
all. Yes, sir.
Okay.
Okay.
Even simple Photoshop is enough to do this, because they are all digitized, digital radiographs, isn't it?
Yes, sir. So
You're not.
we use the software just because if we zoom it, so it won't be, the clarity will be same. So that's why we use the software instead of
In
just
order
using the code.
to make it a more standardized one. Okay, isn't it?
Yes, sir.
Okay. Thank you.
Thank you,
Thank
sir.
Thank you, sir. Now over to you, Dr. Tarun, sir.
Very good presentation. It was in fact a crisp presentation. And you have included all the points, the limitations, the merits. And one doubt I have is when you collect data for Demerjian and Willem and for BEDX, have you compared all the three? Or like did you just do it only for
Voice is not clear, sir.
BEDX?
presentation.
Hear the background new.
There's a lot of background disturbance.
Yes, sir.
Yeah, Harsha, see, doctor, see, were you able to get data for all the three or only for just for BEDX?
So I have done only BEDX. Like I have not compared any two methods.
All right. So, see, you said initially in your presentation that this is a part of Demerjian, right?
So actually, initially to stage the different T, we use Demerjian's method. Like from A to H, we note the stages of the tooth according to Demerjian. And then PEDX has allotted coefficients for particular stage for that particular patient, like for particular tooth also.
Okay, Dr. Harsha, have you heard of the Shailex method? Shailex method? Can someone mute Dr. Ashik? Can someone mute? I would like the organizers to please mute Dr. Ashik Thomas, who is there. Yeah, thank you. Have you heard of the Shailex method? This is also used in a subadult population.
Okay, so I haven't heard of it.
Okay, this is a very much similar age estimation chronological study based on that also. And finally, when you said it was useful in a 7 to 15 mandibular population, that in your opinion, what is it? Is it going to be useful for the Indian population or only for the Western population? Is there anything like that? Have you come to any?
It is useful for the Indian population as well,
Yeah.
because according to our study, the accuracy of the method have been very much pretty good. And likewise, in the study conducted in the South Indian population, it was a study of around 4 states, and the results were quite similar to our study. So this method can be used for the age estimation of Indian population also. So no modifications are required in the formula as such.
Okay, because in your first slide you mentioned 5 to 15 years, right? I think
5 to 15 is the age group which I have used. So
okay, but according to BEDX, was it like that?
the BEDX have used around 6 to 15. 6 to 15.
Because there's a slight.
So BEDX has used for mixed dentition only. So
yeah, because there's a slight disparity on that, right? Okay, fine. Thank you, doctor. Thank you.
Thank you, sir.
Yeah.
Okay, thank you, sir. Thank you, sir, Dr. Rajiva, sir, and Dr. Tarun Varghese, sir, and fellow participants for your prompt cooperation. Now, I would like to call Dr. Rajiv, sir. Sir, kindly receive the certificate as our token of appreciation.
Okay, thank you. Hello.
Dr. Raju, just a minute. Dr. Rajiv, kindly receive the certificate as a token of appreciation.
Okay, thank you, doctor.
Thank you, Dr. Rajiv.
Okay, thank you. Also.
Okay, now I would like to call Dr. Tarun Varghese Jacob sir. Sir, kindly receive the certificate as our token of appreciation.
Thank you very much. I would like to thank the organizers once again for giving myself and Dr. Rajiv opportunity to chair the, a very wonderful paper presentation from a host of intellectual students, who have presented very good papers and varied interest of topics. So wishing the conference all the best. Thank you.
Thank you, Dr. Rajiv and Dr. Tarun, for being part of us in the 5th Triple O Conclave. Thank you.
We are winding.
Thank you.
We are winding up the session. Thank you all once again. எது கேட்கல அவங்க பேசுறது என்ன கேட்கல மேபி அவங்க மியூட் பண்ணிருக்காங்களோ.
Shall I confirm the participants? UG poster 1. UG poster 1. UG poster 3.
Present.
UG poster 4.
Present.
UG poster 8.
Present.
UG poster 9.
Present.
Okay. Good afternoon. Pushpagiri College of General Science is delighted to host Kerala State 5th Annual Conclave. Let's start the scientific presentation under the Department of Oral and Maxillofacial Pathology. Starting with undergraduate poster presentation, now going on to session 6, hall 3. We invite judges for our session. It's my privilege to invite Dr. Shalan Sara Babu and Dr. Gauri S. Dr. Shalan Sara Babu, Professor, Department of Oral and Maxillofacial Pathology, Pushpagiri College of General Science, Tiruvalla. Dr. Gauri S., Professor and Head of Department of Oral and Maxillofacial Pathology, Sri Ramachandra College of Dental Science, Chennai. We welcome you, ma'am. Now let's proceed to the instruction. For poster presentation, you have 5 minutes. You will be given 30 seconds for screen share before the presentation. If your time exceeds more than 30 seconds, the next candidate will be called off and you will be given a chance at the end. You will be given a warning at the 4th minute and proceeded by a final warning at the 5th minute. Sorry, for poster presentation, you have only 3 minutes. After 2 minutes, a bell will be. Okay, I hope the instructions are clear. Now let's start the session. I would like to call UG poster 01. You will be given 30 seconds for screen sharing. UG poster 01. Okay. Okay, next. UG poster 03. Okay, your time starts now.
03, kindly switch on your camera. Yeah. Start presenting.
A very good afternoon to one and all present here. I'll be presenting on the topic Sjogren syndrome. Every year on 23rd of July, we celebrate Sjogren syndrome day in order to create awareness about the same. Sjogren syndrome is an autoimmune disorder where the body's immune system acts against its own cells. We say that here we can have multiple manifestations of the disease, due to which its diagnosis is pretty delayed, and as it spreads to distal parts of the body and leads to complicated situations. Here we can see primary Sjogren syndrome, which is characterized by xerophthalmia and xerostomia.
and secondary Sjogren's syndrome, where the other autoimmune disorders like rheumatoid arthritis or scleroderma, etc. might be present. We can see presence of dry eyes along with a gritting sensation in them. In case of the oral cavity, we can have ropey saliva, fissured tongue. In case of teeth, we can see caries, especially in case of the cervical region. There is also prominent salivary gland swelling. The other symptoms include dysphagia, purpura, joint pain, interstitial lung disease, Raynaud syndrome, and persistent cough. Now, how do we diagnose this disease? We can either do the Screamer's test, where we are going to place a filter paper underneath the lower eyelid, and after 5 minutes, if the level of the wetting is less than 8 millimeter, then we can say that there is dryness of eye. Apart from that, we can also do whole salimetry, where we are going to collect the unstimulated saliva for about 5 to 15 minutes. And if the level is less than 0.1 ml per minute, then we can say there is hypofunction of the salivary gland. The confirmatory diagnosis can be done by taking minor salivary gland biopsy in the labial surface, where we see focal lymphocellulitis. Here we can see foci of lymphocytes are present, and the lymphocytic infiltration is the one which
Ma'am, your last 1 minute.
Ma'am, leading to dysfunction of the salivary gland. If we talk about the treatment, we can either administer artificial tears, fluoride therapy, or salagogues like pilocarpine or cevimeline. Though this disorder is not completely curable, but at least we can control the symptomatic features which we see in this. Thus, we can say that early detection is the key to successful treatment. The patient can always do early diagnosis by getting to know the symptoms earlier and doing diagnosis earlier and combat these symptoms and lead a better and a healthier life. Thank you.
Thank you, ma'am. Now it's time for discussion. Over to you, Dr. Shalin, ma'am.
03, can you please tell me how we are supposed to do the Schimmer test?
In case of Schimmer's test, we are going to place a filter paper underneath our lower eyelid. And after 5 minutes, if the wetting of the filter paper is less than 8 millimeter, that denotes that there is insufficient tear production which is happening, thus denoting that there is dryness of eye and there is xerophthalmia present in this.
What do you mean by this silalog?
Silalogs are those agents which help in production of saliva. For example, pilocarpine, cevimeline, which are cholinergic agents.
Any other drugs?
Ma'am, pilocarpine and cevimeline are the ones I know.
Any other method to induce saliva secretion other than the drugs?
Ma'am, we can take sugar candies. That also stimulates the mouth to produce more saliva.
More than that, anything else?
Ma'am, I'm aware of this much. Sorry.
Okay. It was nice presentation. Over to you, Dr. Gauri.
Yeah, it was a very nice presentation. Can you just tell me what are the other investigations, like apart from you have done a Schimmer's test, right? And labial biopsy. Any other investigations?
Ma'am, in serum, we can observe there can be presence of anti-SSA or anti-SBB, which are autoantibodies which are present. So using that, we can diagnose. And apart from that, we can do whole salimetry. And using certain stains like we have red Bengal stain, which stains the areas which are affected. So staining can also be done. The Bengal stain.
So is it ANA specific for Sjogren's syndrome?
Ma'am, can you repeat the question?
You told ANA, is it? Anti-nuclear antibodies. It's
Yes,
otherwise called ANA, right?
Yes,
is it specific only for Sjogren's syndrome?
Ma'am.
Is it specific only for Sjogren's syndrome?
I'm not sure of that.
Okay. Good presentation.
Thank you.
Thank you, ma'am. Thank you, judges. I would like to call UG poster 04.
UG poster 04.
Kindly share your screen. 04, please share your screen.
Your time starts now.
We are not able to see your screen.
Ma'am, 1 second. Some error is showing. Sorry, ma'am. Next, ma'am. Ma'am, can I do next?
At the last. Proceed to
Okay,
the
ma'am.
next.
Thank you, ma'am.
Stop sharing, please.
Okay, now I would like to call UG poster 08.
Yes, can see your screen. Start
Now
presentation.
Can I start?
your
Yeah,
time
please start
starts
the
now.
presentation.
Good evening, everyone. My topic for today's poster presentation is DNA methylation in oral squamous cell carcinoma. Before starting with DNA methylation, let me just briefly talk about epigenetics. The word epigenetics was established in the early 1940s by a scientist named Conrad Waddington, who used the term to describe how genes interact with the environment to produce a phenotype. Now, there are three main epigenetic mechanisms, which include DNA methylation, histone modification, and non-coding RNA. Out of the three main epigenetic mechanisms, DNA methylation is the most commonly studied one for diagnosis and progression of oral cancer. Now, coming to DNA methylation, what exactly is DNA methylation? DNA methylation is a heritable epigenetic marker involving the covalent transfer of a methyl group to the C5 position of cytosine ring of DNA by DNA methyl transferases. As you can see from the diagram, the methyl transferase enzyme convert the normal cytosine into methylated cytosine or 5-methylated cytosine. Coming to oral squamous cell carcinoma, it refers to the cancer occurring in the vermilion border of the lips and the junction of hard and soft palate and posterior 1/3 of the tongue. Over 95% of persons who have oral squamous cell carcinoma smoke tobacco, drink alcohol, or both. Now, coming to the role of DNA methylation in oral squamous cell carcinoma, higher amount of DNA methyl transferases is a common finding in oral cancer, which leads to the progression, diagnosis, and metastasis of the oral squamous cell carcinoma. As you can see from the diagram, whenever there is an exposure to environmental carcinogen, the methyl transferases convert the normal cytosine into 5-methylated cytosine. As a result of it, the tumor suppressor gene is silenced. As a result of which the progression of tumor cells increases. Whenever there is a presence of PNMT inhibitor, the tumor suppressor gene is expressed, which leads to the slow progression or the stoppage of oral cancer. Thank you all for your
last 1 minute.
Thank you all for your patient listening.
08. Do you mean like the DNA methylation can be used as a potential biomarker in the diagnosis of oral squamous cell carcinoma?
It can be used as a complementary approach.
It's not clear, please. It's not clear.
Ma'am, it can be used.
Yes, please continue.
Ma'am, it can be used as a complementary approach for the diagnosis and progression of oral cancer.
What about the status, whether it is once it is diagnosed by DNA methylation at that phase of oral squamous cell carcinoma, do you think it is a reversible state, or still it will be irreversible when we diagnose with standard HID procedures?
Ma'am, I'm not particularly sure about that.
You're not. Yeah. Over to you, Dr. Gauri.
Yeah. Yeah. So could you just tell me what sort of epigenetic changes it causes in the cell level, in the gene level, or in the DNA level? You were talking about epigenetics, right?
Yeah, ma'am.
Yeah. Does it cause any alteration in the gene expression or in the DNA sequence?
Ma'am, it causes a change in DNA in gene sequence. Epigenetic mechanisms.
No, no,
It
no,
causes
no. In gene expression or DNA sequence,
in
where it
gene
causes.
expression. In gene expression.
What about the DNA sequencing?
Epigenetic mechanism doesn't alter the DNA sequences.
It's not altering.
Oh, yes, ma'am.
Oh. Okay, good.
Thank you, ma'am.
Thank you, ma'am.
Now, I would like to call UG poster 09. UG poster 09, kindly share your screen.
We cannot see your screen. Yeah. Can you please make it in the presenters mode? Okay, start presentation.
A very good afternoon all. Today I would like to present my poster on the topic histone modification in oral cancer. As we all know, oral cancer presents as most complex human diseases and it has multiple levels of regulation. Now coming to oral cancer. Oral cancer is also the uncontrollable growth of cells that can occur anywhere in the oral cavity, commonly occur in buccal mucosa, lips, and cheeks. Now coming to causes of oral cancer. Causes of oral cancer include smoking cigarettes, cigars, pipes, and chewing tobacco, and a family history of oral cancer and include genetic syndromes and chronic facial sun exposure. Today, studies reveal that epigenetics plays a major role in the diagnosis and development of oral cancer. What is epigenetics? Epigenetics include the study of some changes that occur in an organism by the modification of gene expression. Epigenetics mainly include DNA methylation, histone modification, and a role of non-coding mRNAs. Now coming to histone modifications. What are these histones? In our cell, each nucleosome is composed of 4 core proteins that is called histones. And these histones have amino acid side chains that possess basic lysine and arginine residues. And these amino acids undergo some post-translational modifications. And these can also alter the charge density of histones and also cause changes in some chromatin formation. And most commonly occurring histone modifications are histone methylation, histone acetylation, histone ubiquitination, and histone phosphorylation. First, we have histone methylation. Histone methylation is the some changes occurring in amino acids by the addition of 1 or 2 methyl groups. And in histone acetylation, there is some changes occurring by the addition of acetyl groups. Thank you.
Did you complete your presentation? You have 1 more minute.
Okay, ma'am. Now coming to histone acetylation, there are some changes occurring amino acids by the addition of acetyl groups, and these modifications play a major role in the diagnosis of cancer. And this can also alter some changes in chromatin formation and chromatin conformation, and this also can play a major role in the development of oral cancer. Thank you.
Thank you, ma'am. Now it's time for discussion. Over to you, Dr. Sharon, ma'am.
09, can you please tell me what is this ubiquitination?
It's a type of there is some changes in the charge density of histones.
Okay, you have told about three modalities in epigenetics, that is a DNA methylation, histone modification, and mRNA. Okay, which one do you feel the best potential biomarker?
I think DNA methylation is the most potential biomarker.
Okay, how about you, Dr. Gauri?
So you were telling about it causes a lot of changes in the modifications, right? These histone modifications. So can it cause any changes in the treatment modalities? For cancer
I'm not
treatment?
sure.
Yeah.
I'm not sure of this, but we can control the development of cancer by using inhibiting methyl transferases enzymes like.
Yeah, go ahead.
And the drugs that is used as a used for inhibiting DNA histone methylation, acetylation. These drugs can control the cancer.
Okay. Are you now doing this? Are you following this? Or is it under research level?
No.
Are we doing this modalities of treatment right now?
No.
No.
No, ma'am.
Okay. Good present.
Thank you.
Thank you, judges. Now I would like to call UG.
Stop sharing the screen. Stop sharing the screen.
I would like to call UG poster 04. UG poster 04, kindly
Yes,
share.
ma'am. Yes, ma'am. Okay.
Share.
Yeah, please continue.
Okay, good evening, ma'am.
Yeah, good evening. Yeah, start.
Ma'am, how many of you today asked Siri to call someone that you love? And how many of you asked Alexa to turn off the light before you left home? So artificial intelligence has already invaded our lives in so many ways. It has two subsets, that is machine learning and deep learning. So let's talk about how artificial intelligence has influenced our working area, that is dentistry. Artificial intelligence is being increasingly used in dentistry to improve the accuracy and efficiency of various dental procedures, accurate diagnosis, and superior patient care. Here are some examples of how artificial intelligence has helped dentists. First one, the diagnosis of dental caries and periodontitis. Neural network backpropagation algorithm. It's one of the deep learning algorithm, gives a maximum accuracy of 99% in the dental caries image data set with cavities, pit and fissure caries, proximal caries, etc. Then we use for survival prediction of oral cancer, that's in oral pathology. That's with DeepServe. It's a deep learning program based survival prediction algorithm. They improve prediction accuracy and guide clinicians both in choosing treatment options, and thus it avoids unnecessary treatment planning. Then we have intraoral scanners. It's a handheld wireless device used by dentists to scan a patient's teeth and gum. It creates an immediate 3D impression of your teeth, gums, and dental bite that can be viewed by both dentist and the patient on a chairside screen in a real time. Then we have multi-class CBCT scan. The MSD CNN network trained for multi-class segmentation would make patient-specific orthodontic treatment more feasible by strongly reducing the time required to segment multiple anatomic structure in CBCT scan. Then the most famous one, we have teledentistry. That is the practice of using video conferencing to diagnose and to provide advice about a patient over a distance. We have two types of teledentistry. That is
last 1 minute.
Okay, ma'am. Synchronous or real-time consultation or two-way interactive, and we have asynchronous or store and forward. Then we have orthonapic surgery planning.
deep learning method can approximate FEM or facial change prediction in orthodontic surgery planning by accepting geometrically detailed meshes and explicit boundary types. Then we have cloud dentistry, that is the artificial intelligence in dental staffing to match dental jobs with dental professionals. It has disadvantages also, like it's fast but questionable about accuracy. It's technically feasible and cost effective. More than that, the question is it threat to our job? Artificial intelligence can help professionals provide their patients with high quality dental treatment, and dentists may employ artificial systems as a supplemental tool to improve the precision of diagnosis and treatment. Thank you, ma'am.
Okay, thank you, ma'am. Now it's time for discussion. Over to you, Dr. Shaleen, ma'am.
Ma'am, I can't hear you, ma'am.
Not audible.
Yes.
Okay, can you please tell me how the artificial intelligence can play a role in the diagnosis of the basic dental caries?
That it helps for the accurate diagnosis and superior patient care. Like we have, yes, ma'am. We have so many devices like intraoral scanners. In that, we can keep the intraoral scanner, which is a handheld wireless device, and we can see the interior part of our gum, teeth, and all, not only to the doctor, also to the patient on the chair side. So it will give the accurate diagnosis to both the patient and doctor. And we have image scanning systems and all. In that, we'll use computed neural network to understand which are the teeth which has cavities, which are the teeth which has periodontitis, and also it will help dentists in this way.
Can the scanners provide a vision to diagnose periodontitis?
Yes, ma'am, because it can show all the intraoral side. It's an intraoral.
Yeah, but what about periodontitis? With the help of scanners, you can do it.
We can visualize what all problems are there. We can't go for treatment. It's just a diagnosing tool. So it will help for diagnosing, understanding whether periodontitis is there or not.
What's the role of artificial intelligence in teledentistry?
Teledentistry is the video conferencing. Means if in a place, if dentist is not available, we can use the video conferencing. Maybe it can be the real-time video conferencing or the store and forward. Means we'll send video to one particular dentist, and he or she will check that and will send the video, that is the diagnosis and all, to the patient later. Or it will help the patients who doesn't have any dentist nearby, or so that it can help people in this way, teledentistry.
Okay, over to you, Dr. Gaurik.
Yeah, is this your PPT? I'm not able to see. I'm just able to see only artificial intelligence.
Oh, okay, ma'am.
Is that your PPT?
Can you see that now, ma'am?
Yeah. Okay.
Oh, I'm sorry. I didn't know that, ma'am. Sorry.
Okay, it's okay. It's okay. Here I couldn't see certain things. Okay, fine. Now, what do you think is the disadvantage of this AI in the industry?
It's cost effective first and foremost, then it's limited data availability, then accessibility, structure, and comprehensiveness. They learn from mistakes. That's another problem. And to improve the decision making process, and it will cost a patient's life. And it's fast, but it's questionable about accuracy. Then more than everything, it's cost is the biggest problem. Then technically feasibility and all.
So apart from cost and technical feasibility, anything do you think it's a disadvantage?
Maybe it can be threat to our job, because artificial intelligence can invade our profession. So
no, it cannot, because it can only aid. Okay, it can assist, but it can never replace, right?
Yes,
so no need to have any threat for that. Okay, fine.
Okay,
fine.
thank you.
Okay, thank you, judges. Thank you, Dr. Shaleen, ma'am, and Dr. Gaurias. And fellow
Please
participants.
call that 01 again. 01.
Yes, ma'am. And sorry for the delay, ma'am. Shall I present it now, ma'am?
Yeah, please. Start sharing your screen, please.
Is it visible, ma'am?
Yes, ma'am.
Good evening to one and all present here. My topic is omics, a novel biomarker study for cancer metastasis. So, what is metastasis? Metastasis is actually the development of secondary implants which are discontinuous from the primary tumors and possibly in the remote tissues. So, the cancer may spread from a primary site to other sites, which is known as the primary oral cancer. That is from oral cavity, it spreads to other organs like the lungs, kidney, breast, and lips, larynx, pharynx, and then liver. And then the secondary oral cancer is the cancer which spreads from other organs to the oral cavity. That is from lungs, the penis, the kidneys, all the tumors from all these organs is spread and metastasize to oral cavity. So this is secondary oral cancer. So the metastatic tissues actually exhibit high similarities with the primary tumors at the genetic level, not only at the they have similarities at the proteomic level, but at the kinases analysis, they reveal significant heterogeneity between the primary tumors and their metastasis. And the metastatic oral tumors, they can manifest in the oral cavity with occult primary elsewhere in the body. That is, the tumor may be present elsewhere in the body, but the first clinical appearance will be there in the oral cavity. So that is occult primary. And the metastasis of oral cancer
Is it interrupted?
Yeah, we are not able to see your screen.
Yes. And there are theories for metastasis.
There is no screen.
Like how the cancer
There is no screen.
Screen is not shared.
One minute. Is it visible now, ma'am?
Not yet.
One minute. Is it visible now? Hello?
Yeah.
It's
There are various theories for metastasizing of tumors. We have organ theory, adhesion theory, and chemotrection theory. So organ selection theory is the proteins which are and the enzyme changes which are by the metastatic tumors. They will have certain attraction towards certain organs. So based on those attractions, they will go and start a secondary cancer in those sites. And then the adhesion theory and then chemo attraction theory is based on the proteomic changes. The cancer will spread to these organs. And then when during the metastasizing of a tumor, the primary tumor from organ will actually enter the microvascular structure, which is known as intravasation, and then it migrates and transports to other blood vessels of the other organ, and then from there it goes and starts a new tumor in other organs, which is and invasion of the tumor in other organ, which causes the secondary tumor. So usually now during the diagnosis of cancer, nowadays we actually diagnose through conventional methods like taking histopathological study, CT and MRI, whereas in the omic we can study at proteomic level and at the genomic level, the cancer tissues what changes they cause at the genomic level and the proteomic level. We can study at those levels at an earlier stage, and we can detect the cancer before it even shows as clinical features, and we can diagnose it very earlier stage. The conventional diagnosis, we have CT, MRA, and PET scan, whereas in omics level study, we have
Ma'am,
genomics,
your time is
transcriptomics,
up.
proteomics.
Your time is up, ma'am. Thank you, ma'am.
Okay.
Now it's time for discussion. Over to you, Dr. Shah.
It is a nice presentation. Over to you, Dr. Gauri.
Yeah. So, what is that occult tumor?
Occult primary, actually, the tumor will be present in other organs, ma'am, but the first clinical picture or first clinical diagnosis will be made from oral cavity, ma'am. Like it
So
will be
any
manifested as secondary
example?
tumor in
Can
oral
you?
cavity.
Yeah, I can understand. But can you give some examples for that?
Ma'am, like secondary oral cancer, which may spread from breast to oral cavity, ma'am. Breast cancer, which can spread to oral cavity.
Anything else?
And any lung cancers also, ma'am. Because until and unless dentist, the patient sees any clinical features in their mouth or they have any inconvenience in their oral cavity, they come to the doctor and then they get it diagnosed, ma'am.
Okay. Okay.
Okay, thank
Can
you,
go for the
ma'am.
next presentation.
Thank you.
Okay, thank you, judges, Dr. Shirley ma'am and Dr. Gaurias and fellow participants for your cooperation. Now, I would like to call Dr. Shalin Sirababu. Ma'am, kindly receive the certificate as our token of appreciation.
Yeah, thank you.
Next, now I would like to call Dr. Gauri S. Ma'am. Ma'am, kindly receive the certificate as your token of appreciation.
Thank you, but I'm from Ramakrishna Dental College, not Ramachandra.
Yeah. Dr. Gauri, that is noted. Yeah.
Okay, fine. Thank you.
Thank you all once again. We are winding up the session.
Okay, fine. Seven, 3, 4, 5. Leave, but I have to submit this to Shirley. Number. Can leave,
थोड़ा कोई दूसरा क्लिक कर दोगे, दूसरा कोई लाइन का क्लिक कर दो ऐसे ही।
Shall I confirm the participants? Faculty paper 21.
Yes, ma'am, I'm here. Dr. Madhu Narayan.
Faculty paper 22. Faculty paper 22. Faculty paper 23.
Yes, ma'am, I'm here, ma'am. 22.
Faculty paper 23. Faculty paper 24. Repeat. Faculty paper 24. Faculty paper 25.
I'm here.
This is faculty paper 24. Faculty paper 25.
I'm here. 25.
Faculty paper 26. Faculty paper 26. Faculty paper 27.
I'm here. Present. Present.
Faculty paper 28.
Hi, Swati.
Faculty paper 28.
Yes, ma'am, I'm here. 28.
Faculty paper 29.
I'm here present.
Faculty paper 30.
Faculty paper 23 present, ma'am. 23.
PCDS College of General Science is delighted to host Kerala's 5th annual conference. Let's start the scientific presentation under the Department of Oral and Maxillofacial Pathology. Starting with faculty presentation, now going on to session 9, hall 3. We invite judges for our session. It's my privilege to invite Dr. Sunil S. And Dr. Shalini S. Naik. Dr. Sunil S., Professor and Head of Department of Oral and Maxillofacial Pathology, PCDS College of General Science, Kerala. And Dr. Shalini S. Naik, Professor of Department of Oral and Maxillofacial Pathology, PSN College of General Science and Research, Trichy. We welcome the judges.
Okay. Thank you so much.
Now let's proceed to the instruction. For presentation, we have 5 minutes. You will be given 30 seconds for screen share before presentation. If the time exceeds more than 30 seconds, next candidate will be called up and you will be given a chance at the end. You will be given a warning at the 4th month and preceded by final warning at the 5th month. I hope the instructions are clear. Now let's start the session. I would like to call faculty paper 21. Faculty paper 21.
Yeah, good evening, sir. Good evening, ma'am. Can I start sharing my screen, ma'am?
Yes.
Ma'am, may I know if the screen is visible?
Yes.
Yeah, okay. Good evening, ma'am, and good evening, sir. Today, the topic of my presentation is evaluation of the antifungal effect of Terminalia chebula. In Tamil, it is known as Kadukkai, which is an in vitro study. To introduce my study, I took two important opportunistic pathogenic fungi found in the oral cavity, which is the main one, of course, Candida albicans and Candida glabrata. Candida albicans, as we all know, is the most common opportunistic fungal infection, followed by Candida glabrata, and they are known to cause a slew of diseases starting from candidiasis, vaginitis, UTI, etc. And coming to the hero ingredient of my study, which is the Kadaka terminalia chebula. In the Indian medical system, it is called the king of all medicines. Why is it called the king of all medicines? Because of the gamut of medical properties that it possesses. To name a few, I have just listed here a few of them, the most important ones important ones pertaining relevant to our field is anti-carcinogenic, antioxidant, wound healing activity, radioprotective, anti-diabetic, cytotoxic activity. Ma'am? Is there a problem, ma'am? Okay, cytotoxic activity and anti-inflammatory effect. It is also renoprotective and hepatoprotective. So the aim and objective of my study, was to evaluate the antifungal effect of Terminalia chebula, and the objectives to evaluate the antifungal effect of Terminalia chebula on Candida albicans and to evaluate the same on Candida glabrata. The material was, of course, I procured the direct natural seeds available and made it into a powder and then a suspension using the distilled water. I used the aqueous extract of the powder. And the media for both the strains were, for albicans, it was Sabarots chloramphenicol agar, and for glabrata, it was a high chrome Candida differential agar base. These were the microbial strains obtained. And my controls, the negative control was the saline, and the positive control was the clotrimazole antifungal agent. The methodology employed was 10 grams of herbal powder was measured. The standardization was obtained from the previous literature studies. 10 grams of herbal powder was made and used and mixed with 20 ml of distilled water. It was kept for 24 hours and then it was filtered in Wortmann's filter paper, and the extract was kept in the water bath at 40 to 50 degrees Celsius. All these facilities were available in our own microbiology lab, and they were used. They are in-house facilities available. The methodology was, of course, the procurement of fungal strains, culturing the microbes, inoculation of the herbal extract into the strains, and assessment of the antifungal inhibitory zones. Yes, ma'am. Okay. So the inhibitory zone obtained was against the Candida albicans. We got excellent result with my herb, which was 32 millimeter. And with glabrata, we obtained the inhibitory zone of 30 millimeter. And the positive control was, which is clotrimazole, the absolute antifungal agent was only 36 millimeters. So my herb was very, very, very close to the positive controls result. And the negative control, which was saline, was 8 millimeter. So these are all the 3 plates together. This is the graphical representation of my result. 32 millimeter for albicans, 30 for glabrata, and 36 for the positive control. So coming to the major part of my study, which is the discussion, why did I choose Candida albicans? As I've already told, because it's the most common oral opportunistic pathogenic infection. And the main reason for my choosing it was its pathology involved. Candida albicans is the pathology involved is it completely avoids the host defense mechanisms, and it has excellent adherence property to the teeth and of course the oral tissues, and it is known to form a biofilm, and it is highly tissue it has a tissue damaging effect because of the release of hydrolytic enzymes. And the next fungal strain that I used was glabrata, and it is more notorious than albicans because it is known to evade the effect of the antifungal agents. It is very, very
Sorry, is it only me? I've lost the audio actually. I can't hear her.
Your time is up. Thank you, ma'am. Now it's time for discussion. Over to you, Dr. Sunil, sir.
Can you hear me?
Yes, you are audible now.
Sorry, ma'am, can I please get a minute more because of the audio disturbance? I'll quickly finish it. So my herb prevents the formation of biofilm and prevents the adherence property of candida. And the difference between my studies and the previous studies, well, I use the aqueous extract, whereas all the previous literature studies use the ethanolic extract. So though my study is very good to me because it's like my baby. So I will like it however I got the result, but it did suffer from certain limitations. Like I chose only the 2 common fungal agents, but other species need to be analyzed. Other microbes apart from fungus, bacterial, those things can also be tried. Concentrations need to be analyzed because I was doing it for the first time. I used 100% concentration, but different concentrations need to be analyzed. And with practical limitations, I use the basic herb procurement. That is, I prepare the herb powder myself, but the best way is to use Sigma Aldrich powder and the extract, and I use the basic available in my. And the best future perspective is to use the Fourier spectroscope to analyze the amount of extract in my study and in vivo study. So to control the information of Indian herbs in future. These are my references.
Now it's time for discussion. Over to you, Dr. Singh, sir.
Yes, Sally, madam, please.
Yeah, okay. Okay, Dr. Madhu, that was a good presentation. That's a good study. You mentioned that the difference in your study was that you used an aqueous extract. So can you tell me how does that have a significance on the result?
Sorry, ma'am, how is it?
How does it make any significant difference in the result?
Yes, ma'am. Ethanolic extract, of course, there's no difference between the ethanolic extract inhibitory zone and the aqueous extract inhibitory zone. Ethanolic extract, I didn't prepare, I got it in the literature, ma'am. There, the result was 34 millimeter, ma'am, in the previous, the average of all the studies that I got. But I got 33 millimeter, which was almost equal to ethanolic extract, ma'am. Ethanolic extract is more cumbersome in preparation. Aqueous extract was very easy for me to prepare, ma'am, and I was doing it for the first time to evaluate the antifungal effect of aqueous extract for my short study.
All right, that is fine. Similar studies have already been done, and the antifungal property of this particular
yes, ma'am. For ethanolic extract, I have done, ma'am. Yes, ma'am.
It's already been established. The antifungal property of this particular fruit extract has already been established.
Yes. Thank you, ma'am.
Dr. Madhu, as Dr. Stanley madam was telling, was there any novelty in your study?
Sir, sorry, sir.
What is your novelty in your study? There are previous studies showing that the gadkai has an antifungal effect. In spectroscopy analysis, did you add any novelty, any novel idea to incorporate in that?
Spectroscopic study in future perspective. So I need to do it because I got the antifungal agent with my aqueous extract. Has been my aqueous extract proved the antifungal property. My next step would be the FDIR. So,
okay. Next presentation.
Sorry, sir.
Yeah, thank you. We'll go on to the next presentation.
Thank you, ma'am. Thank you, sir.
Thank you.
Very good morning. I would like to present the board and unusual presentation.
Madam, can you please stop the screen? And Dr. Madhu, please stop.
ஐயோ அப்படியா நான் ஏன் இதுல இதுவாயிடுச்சு இல்லையே இதுல இருந்தா இது பண்ணேன் தெரியல நான் பாக்குறேன்டா ஏன் இதுவே வரலையா சந்தியானே வரலையா
I'm 22. Should I start sharing my presentation?
Yeah.
Okay, thank you. Am I audible? Good evening, everyone. My topic for today's presentation is Changing Trends of Age Incidence in Oral Squamous Cell Carcinoma Patient, a retrospective study. Oral squamous cell carcinoma is the leading cause of morbidity and mortality globally, with the incidence varying from one location to another. Several recent reports suggest an increase in the incidence of oral squamous cell carcinoma among young persons in many regions of the world. The aim of this retrospective study was to identify the trends in the age group, gender, different sites, histopathological grading given to the patient diagnosed with oral squamous cell carcinoma. Materials and method. This is an institutional retrospective study done from 2015 to 2022 on the retrieval of the histopathologically diagnosed squamous cell carcinoma cases. A total of 152 cases were included in the study. Data collected for the analysis included the gender, age, anatomical site, habit history, histopathological grading. The patients, they were categorized into the two groups, that is a younger group which comprised of 26 years to less than 45 years of age group, and older age group that comprised of 45 years and above patients. Coming to the results, among 152 cases in the younger age group, there were total 51 cases were being recorded, and in the older age group, there were 101 cases were being recorded. Among the younger age group, the 31 were males and 20 were females, whereas in the older age group, 65 were males and 36 were female, which shows that there was a male predominance as compared to female in both the age group. Coming to the habit history, both in the younger age group and in the older age group, there was the tobacco was most commonly etiological agent being found, followed by the smoking and the alcohol. Few patients, they had the no habit history. Coming on the site recording, under the younger age group, the buccal mucosa was most commonly affected, followed by gingival-buccal sulcus. Hello. Hello. In the older, in the older age group, the gingival-buccal sulcus was more commonly affected, followed by the buccal mucosa. Now, if we see the age among the males and the female in the younger age group, in both the age group, the buccal mucosa was most commonly affected in the males and the female in the younger age group. Whereas coming to the older age group, gingival-buccal sulcus was most commonly affected in males, whereas buccal mucosa was most commonly affected in females in the older age group. Coming to the histopathological grading, among the younger and the older age group, well-differentiated squamous cell carcinoma was most commonly affected, followed by moderately differentiated squamous cell carcinoma. If we see under the younger age group, in the females, the 3 females out of the 20, they showed the variants of the squamous cell carcinoma, which was followed by 7 cases of moderately differentiated squamous cell carcinoma and other well-differentiated squamous cell carcinoma. This shows that the female, they had more aggressiveness or more grades of squamous cell carcinoma as compared to the males in the younger age group. Coming to the discussion, oral squamous cell carcinoma is a major health problem in the region of the world where tobacco habits in the form of chewing and or smoking with or without alcohol intakes are common. With the change in the dynamics of the society, there is an increase in the tobacco consumption by young adults, and the rising prevalence among the women is also seen, which could be because of the social acceptance of the socio-cultural factors, easy availability of the products, advertisement, low cost, etc. The buccal mucosa is, according to the Indian literature, the buccal mucosa is the most commonly site being affected, whereas the Western population, it shows that the tongue is the most commonly affected site. Coming to the conclusion, study of the prevalence pattern from the different parts of the India may help in devising specific strategies for reducing the risk of oral cancer. Further, such studies should be done for a longer time period at different levels of reference center may help us in identifying the prevalence pattern of this alarming disease so that prevention activities can be carried out in order to decrease the incidence and mortality rate due to cancer. This emphasizes the need for a mechanism of methodological tabulation of the patient data, metadata, including the electronics. The limitation of my study was due to the missing information. The TNM staging were not being recorded and some lack of uniformity annotated informations. These are my references. Thank you.
Thank you, ma'am. Now it's time for discussion. Now over to Dr. Shalini, ma'am.
Okay, Darshana. Yeah. Yes.
Yes. Good evening, ma'am.
Okay, good evening. So, what is the inference from this study? Did you find any significant factor which was different in the younger individuals and the older age group study?
Yes, ma'am. Ma'am, according to the studies, there are very few studies being done in the India, which is doing such epidemiological studies. And also the most in the Western population, it was found that well-differentiated squamous cell carcinoma was the most common. But when we studied that, we found that moderate and the variants were also being studied. And also the females, they had the more consumption of tobacco products along with the other etiological factors.
Was there an increased prevalence among females in the younger age group?
Yes, ma'am.
Did your study show that result? It's almost, yeah, maybe a marginal increase in the female population. Okay, so anything, can you infer anything regarding the etiological? It's only the habit difference that has led to increase incidence of squamous cell carcinoma in the younger age group?
No, ma'am. It can be because of other factors also. But just we had the whatever data we had from that, we can say that tobacco can be one of the, as it is the common etiological factors. So it could be again the helping in the increasing the prevalence rate or incidence.
Again, in the habit, there's not much difference between the alcohol and tobacco consumption in the two age groups.
Yes, ma'am. But the tobacco was more as compared to the smoking and the alcohol being recorded, ma'am.
Thank you, ma'am. Now over to you, Dr. Sensor.
Thank you, ma'am.
Okay, now I would like to call faculty paper 23. Faculty paper
23.
Yeah.
Can I share my screen now?
Ma'am, kindly share your screen.
Ma'am, is it visible, ma'am? Ma'am, is my screen visible? Can I share?
Yes, please start.
Good evening, sir and ma'am. Today I'm going to present a study on antifungal property appraisal of traditional herbs against Candida, an in vitro study. A general introduction regarding the oral candidiasis. It is a common antifungal infection in the oral cavity, which is mostly caused by the Candida albicans, and it is also said to be as the most common opportunistic infection in HIV and AIDS. And diabetic patients and the patients, those who are using antibiotics for a prolonged period, and patients who have underwent radiation therapy are most prone to the oral candidiasis. When the infection spreads to the bloodstream, it is called as candidemia. Through the bloodstream, the Candida infection can also spread to the other parts of the body like eyes, kidney, and brain. That is called as invasive candidemia. So treatment of candidemia or treating the candidiasis is the most important thing in our regular life. So the patient those who are suffering with the oral candidiasis can suffer with severe oral discomfort, pain, loss of taste, and aversion of food. So usually we have antifungal drugs like nystatin oral suspension, clotrimazole patches. In case of any systemic prescription, we're using ketoconazole, fluconazole, and itraconazole. But due to increase in fungal pathogens and limited therapeutic options, and with certain side effects of therapeutic drugs, we are just having some trial over the traditional herbs, which may help in the treating the candidiasis. So we aim to find the antifungal property of curcuma cassia, that is black turmeric, and spirulina, which is called botanically it is called as Spirulina plantis, against Candida albicans and glabrata. We have done it as an in vitro study. A small intro regarding the black turmeric. Black turmeric is called as a perennial herb and it belongs to the family Gingiberaceae. It is a native bluish black rhizome plant of northeast and central India. The rhizomes of black turmeric will have a very good medicinal property, and because of these property, they have having also a very high economic importance. And these rhizomes are treating leukoderma, asthma, tumor, piles, bronchitis, etc. A short note on the spirulina. Spirulina is a cyanobacterium which is also used as a food as well as the medicinal property compound, because it is having a high quality and quantity of proteins, amino acids, and polyunsaturated fatty acids and vitamins. So spirulina is also said to prevent an oxidative damage, and it can even indirectly reduce the cancer formation in our human body. So with all these properties, we have chosen black turmeric and spirulina planters, which is there are not much studies has been done in black turmeric as well as in the spirulina regarding the antifungal property. So our objective is to find the zone of inhibition for black turmeric against Candida albicans and glabrata, and also to find the zone of inhibition of spirulina against albicans and glabrata. We have even compared the antifungal efficiency of black turmeric as well as the spirulina. Moving on to the materials we used, we purchased a black turmeric dry powder, and we also purchased commercially a spirulina dry powder with clotrimazole will be is being used as a positive control and normal saline as a negative control. Moving on to the method of preparation for the alcoholic extract of black turmeric, 5 grams of powder has been weighted and it has been soaked in 10 ml of absolute alcohol. It has been left undisturbed for overnight. Finally, we have centrifuged the solution. The clear visible part over the test tube has been taken and which is used as the stock solution for the experiment. So this is the extract which we prepared. Moving on to the preparation, alcoholic preparation of spirulina, 2 grams of powder has been taken, which is soaked in the 10 ml of methanol, and the complete mixture is agitated for 60 minutes. For every 50 minutes of agitation, we are interrupted by adding 10 ml of methanol into it. After 16 minutes, we have filtered it, but here we have taken the filter powder and we have not taken the liquid. The filter powder, again, it is washed with the 20 ml of hexane, and the procedure is repeated twice. Now the powder has been evaporated in the hot air oven at 40 degrees Celsius and it has been dissolved with 25 ml of distilled water. Finally, the extract is prepared and this is the prepared extract. We have used the well diffusion method where 100 ml of Candida albicans has been taken and 100 ml of Candida glabrata media has been taken in the media. Hello?
This is your last night. Yeah.
4 mm of well has been created. And the results, we have a 36 mm zone of inhibition positive control. And negatively, we have spirulina, which showed 26 and black turmeric for 21. And glabrata 36 positive control, while spirulina showed 25 and black turmeric 21. We also compared the black turmeric and spirulina against albicans, it showed 26 and 21. In glabrata, spirulina showed 25 and black turmeric showed 21. So with all the discussions, there are many antibacterial studies for the black turmeric, but antifungal studies has not been done still. So Manish Kumar et al. Have found that there are antifungal property for black turmeric, and Nitish Kumar also found that it has been showing some positive results against gram-positive bacteria. But Yogamaya et al. Have done the antioxidant property, and they have also found that 3 species of black, including the black turmeric, is also having the antioxidant property. Regarding the spirulina, spirulina has not been used.
Thank you. Now it's time for discussion. Over to you, Shalini ma'am.
Okay, Dr. That was again a very similar study, similar to one we heard in the first paper. So the inhibitory zone was better, or it was more for the spirulina compared to
the black turmeric.
I just wanted to know, for my out of my curiosity, why was there a difference in the extraction method for the black turmeric and the spirulina?
Ma'am, for the black turmeric, we have taken the extracted liquid powder, ma'am. For it has been taken for the finally, but for spirulina, initially the powder has been taken and then we have proceeded with, then we have dissolved it in the water to get the extract, ma'am. So in the previous articles, for the procedure of extraction for spirulina, because it takes a long time for the complete extraction process, they have used it. We have followed the methodology for spirulina.
Okay.